drugs could be in grams. I'd say the most common is milligrams. Also, pediatric dosing is by weight. So it'd be milligrams per kilogram, something that's very common. Again, you could also have micrograms per kilogram. Just know that there's different dosing, right? Milligrams, give me an example. If I was to give somebody 100 milligrams versus 100 micrograms, milligrams is more, just so you're aware. Special considerations, for example, very common is a special consideration. If someone's pregnant, caution the use on this. Give you an example. If someone's elderly or if someone's a pediatric, right? So certain types of patients, you might want to caution. It's not saying don't give it. It's saying think about it. Special considerations. And then finally, the class of the drug. So what family does the drug belong to, right? So I'll give you an example. We talked about a few different meds. So we talked about oxycodone. That's an opiate, right? That's the class it comes from. Epinephrine. It's a sympathomimetic. Epinephrine is going to enter your body and it's going to mimic your own sympathetic nervous system. Blood pressure up, heart rate up, lungs open, right? So here we go. Now the brand name, also known as the trade name, I like to refer to as like the marketing name. So you might see on like TV commercial, like to get you to remember the drug. So another way to look at it could be like the business name or the corporate name, right? That's the brand name of the drug. It's called brand or trade name by the books. Think of it as the marketing name. So for example, let's say we were talking about the drug. Let's say it was Advil, right? So Advil would be your brand name. Your generic name would be ibuprofen, right? So the generic name is closer to the chemical name, but it's clear and concise so people can actually, read it. A chemical name is what the drug is referred to in a lab setting. It's extremely long. It'd be, as long as its entire sentence, basically. So we're never going to see that in medicine. That's for, lab scientists. Now, prescriptions versus over-the-counter. Prescriptions are by a physician's order, so you have to see a doctor for that. And then over-the-counter would be no orders needed. You can walk in the pharmacy and then just go buy it. Now, real clear, I want to talk about something real quick. Brand name drugs versus generic drugs, it's the same exact drug. There's no difference in the drug. One is a brand, one is generic. The generic is just cheaper. That's all it is. It's the same thing. So, same drug, same chemical. And this is the same drug throughout. Just want to make sure it's clear. It just goes by different names, right? To put it in your brain to remember, a generic name might not be as palatable for marketing as the brand name, hence why they have the brand name to remember in your head. There it is. So we've learned a little bit here. Now I want to talk about the actual route of how the drugs enter. Let's talk about that. So these are some of the more faster ways. And I would also say, I just ran a room here, but intramuscular would also be pretty fast as well. And then you have some of the more slower ways here. These would be the 3 slowest. There's no particular order. I'm just giving you an idea to plant in your brain. If you go along like this, it gives you an idea of how fast it is. So intravenous. So that is starting an IV in the patient, and we're going to place a catheter into the patient's vein that will allow drugs to go through that plastic catheter into the vein directly. Intraosseous, that has to do with entering drugs in the bone marrow. At the advanced DMT and paramedic level, what you're able to do is you're able to actually drill into the patient's bone, commonly either up here in the humeral head or down on the leg and down by the tibia. And what you're going to do is drill in there, and then you're able, through that catheter that you've now made, put medications through there right to the bone marrow. So that's intraosseous access, IO access. Inhalation. Inhalation would be, for example, someone with a inhaler, or you giving the patient something through a nebulizer. That's inhalation, right? Intranasal, that would be, for example, you have a medication, you hook it up, and you can into the patient's actual nose itself. Sublingual is underneath the tongue, right? So, for example, nitroglycerin is very popular sublingual. And then per rectum, a lot of times we're thinking about rectum medications with pediatrics. So, for example, this could be giving seizure medication, for example, to a pediatric would be PR. Now, in EMS, we don't give stuff rectally. That would be like at home, a parent or something like that, just to give you an idea. Young children, well, would be in that. Intramuscular would be obviously into the muscle. So EpiPen is into the muscle, and into the muscle could be here as well. So intramuscular. By mouth is just taking pills, liquids if you're a child. Then subcutaneous and then transcutaneous. So sub-Q is just underneath the skin, but we're not into the muscle. And then transcutaneous would be like topical. If I had like a paste or I was rubbing like something onto my skin, that's transcutaneous, right? So in EMS, which ones are used the most commonly? Well, we talk about paramedic, advanced EMT level, IV, IO. Now at the EMT level, we can assist with inhalation. In some areas, you might be giving inhalation drugs, right? Intranasally, of course, that's EMT level. So, for example, this inhalation would be like your albuterol, would be like ipratropium. Intranasal would be like naloxone, for example. Sublingual would be nitroglycerin, for example, right? By mouth could be like ibuprofen, right? Aspirin, right? Just to give you an kind of an idea. And at the paramedic level, IV and IO would be very common. Obviously, advanced EMTs would learn the IV and IO skill as well. This right here is our 9 patient rights. So with patient rights, what this means, we are talking about the patient having 9 rights to them receiving a medication from you. It is your job, your responsibility as an EMS provider to check these rights to ensure you don't make a medication error or do something that might harm the patient. Now, one of the biggest things before we get into each individual right is remember, what's one contraindication that every patient's going to have? If they're allergic, you got to ask your patient, are you allergic? An allergy stops this whole process, okay? So besides that, let's continue. Right patient, okay. Right medication, right indication. So we have the right patient. We have the right medication that matches the indication. That makes sense. Okay. We have the right dose. Okay. We're going to choose the right route to give the drug. Okay. We're going to document the right time to give the drug. Also, meaning right time, is this the right time to give this drug? Like, is the next dose due, you could say, right? Right education means giving the patient themselves education on what is about to happen, right? A brief education. Hey, I'm going to give you this drug because it's going to help you with your pain. I'm going to give you this medication. It's going to help lower your heart rate. I'm going to give you this medication to make sure that the vomiting will now stop, right? Stuff like that. Right to refuse. The patient could refuse the medication. They have the right to. If they're of adult years and of sound mind, they have the right to refuse. What if they're not? What if they're confused? What if they're altered? What if they're on drugs or alcohol? What if they're unresponsive? Then we have to make a judgment call on what is best for the patient, and that obviously is under another video, under medical legal. But what we're talking about here really is the patient's right to refuse if they're adult of sound mind. Now, right response and evaluation. So what does that have to do with? Well, that has to do with is the patient response what you believed before giving the medication. Are we seeing a desired effect? And then evaluation means doing physicals, doing vital signs, reassessment after giving the drug. Then right documentation is you got to document the whole call. And there it is. Let's start here with some key terms. So we have infectious disease, which simply is growth and spread of small harmful organisms in the body. So we think of bacteria, of viruses in the body, right? Well, there are 2 main pathways, bacteria and virus. And we're going to describe different types as we go along. Now, communicable disease. All that means, think about this. The word community is in here, right? So meaning that we have a disease spreading from one person to another. So I think community is about different people. So disease can spread from one person to another, right? Very simply. Now, 2 other key terms I want to mention. What's an epidemic versus a pandemic? An epidemic means there are new cases of the disease in a certain area that exceeds what is normally expected based upon recent experience of the past, right? That is an epidemic. A pandemic is when this epidemic reaches global scale, the global level. That's a pandemic. So these are the first key terms. Let's continue. Now, there are 5 main causes of infectious disease. So bacteria, viruses, fungi, protozoa, and then helminths. Now, with bacteria, I'll give some examples here, okay? These could be a curveball test question. I want you to, well, where'd that come from? It's right here. I got you. Look, salmonella, type of bacteria. Influenza, a virus. Mold would be fungi. Protozoa would be like amoebas. Worms or helminths, right? So, these are your 5 main causes of infectious disease. Remember, an infectious disease is when an organism, these are your 5 types of organisms, that can enter our body and cause trouble. So here is influenza, commonly called the flu, is influenza. Now, when we're talking about influenza, it can affect the very young and the very old. Remember, this is a communicable disease. So, there's chronic conditions, very young, very old. These are people that are going to be the worst affected by the flu, right? Have more sinister signs and symptoms, right? So, a more mild case of flu may be a period of a few days, maybe up to maybe a week, few days at the minimum. Fever, chills, cough, sore throat, general weakness, malaise. You'll be in bed for a few days. Maybe some nausea, vomiting. Now, those that are, for example, maybe they're on the older side, have chronic conditions, they're at risk of the flu potentially being a life-threatening event. It can happen in elderly patients, right? This can cause shortness of breath, can cause respiratory and cardiac complications because of the age and or chronic conditions, right? So, obviously, we want to treat the patient's symptoms in the ambulance. As far as a flu treatment of EMS, treat their symptoms, right? Position of comfort. If we're able to treat some of these symptoms that they're having in the ambulance, fantastic. So let's move on. Now let's discuss the COVID-19 virus. So the first thing that's very interesting about COVID-19 is the wide range of symptoms and outcomes. So same virus, but we can have one person that has a great outcome and the other person has a bad outcome. That's the thing that made COVID-19 so sinister, right? Now, the good thing about COVID-19 is there's been so many cases so that now it is easier to treat than it was in the beginning, which was late 2019, early 2020, to give you an example, right? So, you have to understand, if someone has COVID-19, there can be a range from mild symptoms that last 3 to 5 days to some people that have chronic symptoms because they caught COVID-19, then other people that have a bad outcome and actually pass away due to COVID-19. What does this sound similar to? Well, it sounds similar to how I talked about the flu, a little bit, right? Yeah, they're now different virus, but similar in the aspect of the flu can be mild or the flu can be life-threatening. And also, the difference here, the main difference, is COVID-19, oddly enough, comes from the same family of viruses as the common cold. Again, this is a very obscure virus, as we can see so far, right? Now, let's continue a little bit more. So, by the records, the very old and or people with chronic diseases tend to have a harder time with COVID-19. That's not a rule because of the wide range of symptoms and outcomes, right? But that's a thought to have about the COVID-19. Now, diabetes, respiratory and cardiac conditions are going to be more at risk. That is what we've seen. Now, what are some signs and symptoms? There's a lot here. I'm going to read them out to you again. A wide range of them. So fever, chills, cough, fatigue, muscle and body aches, headache, sore throat, loss of taste and smell, nausea, vomiting. Now, that I would say is more on the mild. These are the signs and symptoms, this first part here, that you may get for a period of, let's say, 3 to 6 days, right? Maybe even up to a week. And then they slowly get better and better over time. What tends to happen, and again, tends to, because it's a wide range, usually 2 to 14 days. Let's say you're exposed to the virus. Some point in 2 to 14 days, you're going to have symptoms. That's how long they're going to last after actually the virus getting inside of you, right? Now, right here, if it gets worse or if you're at a more risk end, shortness of breath, chest pain, confusion, cyanosis. Those are the patients that are in hospital being treated. So those are our main signs and symptoms. Let's move on. Whooping cough, also known as pertussis. Now, here are words. Here's what we're looking at. So it's an airborne disease, typically under 6 years old. So we're thinking whooping cough is in pediatrics. Now, it's a bacteria. There are 2 different vaccines that are available that can help prevent getting the bacteria that causes whooping cough, right? Now, signs and symptoms. Fever. So why they call it a whooping cough? The patient first is going to have intense coughing bouts, right? So intense, long durations of coughing, very severe, right? With sore throat, with fever. The reason they call it the whooping cough, after these coughing bouts, you'll hear a whoop type sound as the patient tries to inhale during or after these coughing bouts. That's why they call it whooping cough. And this lasts 1 to 2 weeks. And the cough can linger on as well. So that's whooping cough. TB or tuberculosis is a chronic disease that affects a patient's lungs. Now, the thing with TB is this. You have a primary infection. And you can actually get TB. So your TB can enter inside of your body, right? And I'm going to explain how it works. Mainly, it's usually through droplets in the air, okay? Now, TB, you can have a primary infection. And then the TB will lay dormant in you for years. It may never reactivate. That's good, right? Right. The other option is your body may get exposed to TB, but it wasn't strong enough to actually make an effect. But it might show up, for example, on a TB test that's done, but it's not actually active TB. It's just dormant, right? Or it wasn't enough to actually cause an infection, right? It's said that 1/3 of the whole world actually has been exposed to TB. But the thing about it is in the air, it's not very strong in the air, TB. So it can get diluted pretty easily. I hope that makes sense to plant that in your head. So let's go through a few more here. So primary infection, then TB lays dormant. It's usually what happens. Now, it is possible for the TB to, if you have a primary infection that's active, it is possible for it to reactivate years later, but it doesn't always happen, okay? Now, TB spread through airborne transmission. What this means, if you have a patient in your ambulance that has active TB, you should wear an N95 mask. That one, and I would also put the exhaust vent on in the ambulance as well. Again, someone could be in contact with TB, but symptoms or active status never occur, right? Now, N95 should be worn for active TB patient. We talked about that. What are the main signs and symptoms? Well, here they are. Chronic cough, that would last over 3 weeks, okay? Weight loss, fatigue, chills, and pain while breathing. So what TB is going to do is enter the body, go down to your alveoli, and the bacteria will start growing down the alveoli. That's TB. Now here's meningitis. So meningitis, we're going a little different now. We talked about some of the lungs and upper respiratory infections. Now we're talking about the brain and spinal cord. So remember, anything that ends in itis means inflammation of the meninges. So the meningeal layer of the brain spinal cord is inflamed, is infected. So inflammation of the meningeal layer of the brain spinal cord. Signs and symptoms. So fever, headache. The big key is the stiff neck. Their neck is very painful and stiff. Could cause, in later stages, altered mental status, malaise, fatigue. You're most likely going to see this patient coming from, let's say, a doctor's office. They went there, I feel kind of have flu-like symptoms. I don't feel I have a stiff neck. Maybe from an urgent care, a student care center, a medical office, and they're going to call and say, hey, you're ill, you need to go to the hospital. I've had that happen so many times from meningitis. So that's something that can happen. Keep that in mind. Now, there's one form of meningitis that is very highly contagious, and it is spread through respiratory droplets, coughing, sneezing. So what you need to do, any patient with meningitis, you need to place a surgical mask on the patient. So that way their droplets aren't spreading about. Okay? Now, severe headache, photophobia, which means like, they don't really want to look at the light, and then flu-like symptoms. Those are going to be some other key things to add with these signs and symptoms to think this could be a worsening meningitis. Severe headache, real flu-like symptoms. Usually it looks a little worse. It's more contagious. Now, what does this mean? Any patient that you suspect, quite simply, they have a stiff neck, they have flu-like symptoms, treat them as if they have the worst kind of meningitis that's highly contagious. Put a surgical mask on the patient. You should be donning N95 yourself, exhaust vent in the ambulance, radio patch the hospital. Let them know you're bringing a patient that possibly could be highly contagious, so you can set it up appropriately. So you don't just walk into triage with someone with meningitis and everyone's all around you, right? Now, the lab tests in hospital will determine what kind they have, but we want to treat worst case. HIV and AIDS. The biggest pearl with HIV and AIDS, the patient's immune system is under attack. It's depressed, it's not strong, it's weak, which is why they are prone to so many recurrent infections. Now, with HIV, if nothing is done and they're not treated, which is rare nowadays, what would happen is they would have a primary infection a few weeks after being in contact with the virus. And then it goes into a period of asymptomatic. Then you have symptomatic HIV, then you have symptomatic AIDS, which will result in the patient's death. Now, the thing about the way medicine is today is the HIV medications, when taken, and obviously this is part of why people get tested, the medications are so good at what they do nowadays that HIV patients can almost live to near, their life expectancy is almost near normal because the medications are so strong. Obviously, the earlier you catch, the better. Now, quick pearl. How is HIV contacted? Blood, sexual contact, bodily fluids, needles. Now, as EMS, obviously, we're talking about anything, what we would do. Cover your own wounds and cuts. So even a small cut, obviously, if blood goes on there from a patient, that can cause something, right? So cover your own, if you have a cut on your finger or hand, make sure it's covered up. Wear gloves if we use a needle, relatively an IV or an injection, whatever, sharps away, right? We don't want to do a needle stick to ourselves, right? So again, weeks after infection, the patient's going to have flu-like symptoms, fever, sore throat, fatigue, could have some weight loss, but that's more later on, but just some ideas, nausea, vomiting, right? Then, asymptomatic until AIDS occurs. If AIDS occurs, this is where we have weight loss, recurring infections, night sweats, fevers. In your area, there may be certain clinics that house HIV and AIDS patients. It's a very common call to go there because they're having recurrent infections like pneumonia, for example. Now remember, hepatitis. Hepa, if you hear hepato or hepa, we're talking about the liver. Where's my liver? This is my right hand, right upper quadrant sits the liver. Quite a large organ. It's going to sit in our abdomen, right upper quadrant. Now, the biggest thing about hepatitis to remember is there's two pathways we can get hepatitis. Well, by a virus or just damaging our liver. So remember, hepatitis, all that means is the liver is inflamed or infected. In this case, it's infected liver. Now, you may have heard alcoholics, for example, to give a patient example, would have hepatitis, but not from a virus, due to damage. Key, all right? So we're talking about viral hepatitis. You can see 5 different letters here. So hepatitis A, hepatitis B, C, D, and so on. The 3 in the middle, this is the way I remember it. B, C, D are all blood and sexual contact. A and E, which actually that's a good mnemonic, A and E, right? The brand A and E. So A and E, right? There's a mnemonic for you. A and E are both fecal-oral route. Now, what does that mean? So, hepatitis A and E are spread through the fecal-oral route. It means fecal matter of someone that was infected gets placed on something that you eat or drink. Could be drinking water, could be food. So this is A and E, and then you have B, C, D in the middle, blood sexual contact, right? Similar to HIV, right? So, signs and symptoms. Jaundice. So if you don't know what jaundice is yellowing of the skin and the patient's eyes. So that's jaundice appearance. Nausea, vomiting, abdominal pain, mainly over the right upper quadrant. Nausea, vomiting, yes. Fever, chills, loss of appetite and weight loss is always a sinister sign in any patient, so watch out for that one. Starting off with hematology is anemia. So anemia is a condition where we either have too low of hemoglobin or we have too low of red blood cells in general. It can be and, it can be or. Remember that hemoglobin is part of our red blood cell. The hemoglobin is going to actually be the binder to oxygen, and then red blood cells carry that oxygen. So we have a big problem with oxygenation if we have an issue with our red blood cells. Right. Now, with anemia, I'm just going to read this out to you here. It's a condition where red blood cells and or hemoglobin levels are low in the blood. Now, a great follow-up to this hematology series here is going into anatomy and physiology in your section and reviewing hematology there as well. They give you some more pearls about the A and P of all this. This is going to be focusing on diseases and emergencies and signs and symptoms. Now, anemia is the symptom. What's the culprit? What does that mean? So if someone, let's say someone presents and they say, oh, I have a low hemoglobin level or a low hematocrit level, they have a low red blood cell count. That itself is the symptom of, well, what's going on? Are they bleeding? Is it a disorder? So we have to figure out why is it low. Similar to if we get an SpO2 on somebody, right? We have to figure out why are their oxygen levels low, and then what do we do to fix that, right? Get where I'm going with this? So it's the same thing with anemia, right? So iron deficiency anemia, and then we have hemolytic anemia. So iron deficiency anemia, let's start with why. What's this big deal with iron and red blood cells and all this stuff? Everyone talks about iron. If we have a low level of iron in our body, we don't have enough iron to do what we need to do. What happens is iron is crucial for oxygen to bind to the hemoglobin. So if we don't have enough iron in our body, then we have a decrease in the oxygen absorption with hemoglobin, right? So iron is crucial to hemoglobin. Iron gives hemoglobin the ability to bind to oxygen. We need iron in our body, right? Now, what are the risk factors of iron deficiency anemia? Heavy menstrual bleeding, pregnancy, and also stomach disease. So we think about, in general, bleeding, pregnancy, we have someone else take care of inside of us, and then stomach disease, right? Stomach disease, obviously, we're having in that case, it could be a peptic ulcer disease, any sort of stomach disease. If you had surgery in your stomach, for example, right? So we talk about bariatric surgery. That can be an issue, right? So the stomach obviously is going to absorb a lot of the stuff coming into our body, so we can have an iron issue there if we have a stomach problem, right? Now, hemolytic anemia is completely different. It's either an inherited disorder or it can be something that you can get later in life. Now, I want to share this with you here. Hemolytic anemia is usually two main things. A deficiency in certain enzymes in your body, which causes anemia, or it's an inherited disorder and you've lived with it. What is hemolytic anemia? Hemolytic anemia means the body is destroying red blood cells before they're actually ready to be destroyed. So obviously the body is always cycling red blood cells to create new ones. So imagine we have a red blood cell that's nothing wrong with it, and it gets destroyed too early. That process keeps happening, you're going to end up being anemic, hemolytic anemia. So this is a start. Now, let's go over a little more, and let's talk signs and symptoms. Now, here are our main signs and symptoms of someone being anemic. So the biggest thing that we look at here, as you can see, fatigue, lethargy, malaise. That's basically 3 different ways of saying I'm tired, right? So your patient's going to be extremely tired, more tired than their baseline. Now here's a few other ones that we look at. Headache, and then bleeding. Obviously, bleeding could be external or internal, and then possibly fever. So on the scale of this, let's say it's a mild anemia, fatigue, lethargy, malaise, some sort of internal or external bleeding, right? Headache, it gets worse. Fever gets worse. Breathing difficulty, chest pain, right? That's what we're looking at. Now, EMS-wise, what is our treatment plan? So we're going to support their symptoms. We're going to do a full patient assessment. We want to make sure to get a blood sugar, and then obviously, if we're at a paramedic level or we want to consider getting an EKG, then make sure to get a pulse oximetry, and if they need oxygen, give oxygen. So that's going to be our goal. Mainly in EMS for an anemic patient, it's going to be supportive. That's going to be the goal, obviously. Now, if the anemia is severe, under this, really severe, really, really low, as far as their H&H levels, their hemoglobin and hematocrit levels, the patient may require a blood transfusion at hospital. Sickle cell disease is an abnormal size and shape to the patient's red blood cells. So I'm going to show you first what a picture here. Now, this, which is plain circle, is basically a picture of the normal red blood cell. So just imagine in your head, look at the surface area I have for oxygen to land on. It's like a large disc, right? Now this sickle cell, look at the difference. The surface area difference is completely changed. Now it's in the shape of a sickle, which is like a sickle cell, right? So this is a sickle cell red blood cell. So just off the bat, before I tell you anything else, sickle cell disease means your red blood cells are abnormally shaped and your oxygen capacity at baseline is lower than most people. So that's just from the baseline. Now I have more to tell you about. First, this is inherited. So this is inherited through family, right? Now, the next thing we're going to talk about is down here, which is red blood cells can get caught in vessels, causing clots. Sickle cell crisis can be life-threatening. Here are the signs and symptoms. Let me explain all this right now to you. So here we go. Sickle cell patients, because their red blood cells are shaped like a sickle and they're abnormal, they are at risk of getting what we call sickle cell crisis. What sickle cell crisis is, it can happen anywhere in the body. So you pick a spot, it can happen anywhere in the body. A patient will develop excruciating pain in the area that's being affected. Also they'll be more tired, they'll be in pain, they will know something's wrong. So what can happen with sickle cell patients is that sickle, because it's shaped like that, we can get blood clots in the body. And this can even happen in multiple areas. So if you pick an area in the body, it can be affected by sickle cell disease in this sickle. Now, obviously this doesn't happen all the time, but it can be a recurring thing that happens to these patients. They have to call EMS, they have to call and go to the hospital. The signs and symptoms of a sickle cell crisis is excruciating 10 out of 10 pain. Could be on the chest, could be on the back, could be headache, extremity, joint pain. Now what I've written down here is extremity and back pain, chest pain, shortness of breath, jaundice if the liver's involved, right? Joint pain, fatigue. Picture that there's a clot going on in the body right now. This is an emergency and it can be life-threatening. Sickle cell crisis. Now, the one I didn't write down, there is a disorder called acute chest syndrome with sickle cell patients that usually accompanies some sort of respiratory infection where the lungs actually get involved. So you may see in that case, again, chest pain, shortness of breath in that case too. Now, we want to ask ourselves, why would a patient with sickle cell crisis suddenly just go into crisis? Is there a reasoning behind it? Yes, there are some risk factors to having a crisis. If they're dehydrated, if they've been exposed to extremes in temperature, in a recent infection, a lack of oxygen in an area, a strenuous physical exercise, or just stress or trauma injury itself, right? Now, as far as the patient's concerned, obviously they want to keep hydrated and electrolytes. Now, as far as we're concerned, if the patient appears to you and they are, hypotensive, hypovolemic, well, in that case, we want to obviously give IV fluids, electrolytes, etc., right? Then what are the big keys here? We want to keep their SpO2 above 94, 95%, right? Get it above that level. Get them back to their normal. Pain management is the big key here with these patients. So the paramedic level can give narcotic pain medication. This is a severe pain when they have a crisis. Now, the last thing I want to talk about is with hydration. We do not want to overhydrate these patients. So we want to reserve like giving IV fluids to patients that really need it, that are severely dehydrated or hypoperfusing or hypotensive. We don't want to just throw fluids at this patient just because they're in crisis. The main thing is going to be the O2 and the pain. Then you can consider this. That's a thought. Now let's talk about leukemia. So leukemia is several different types of cancer that can be grouped in under leukemia. So with leukemia, it's going to destroy your white blood cells. But also, and there are different types, but the thing with leukemia is it's ultimately going to affect all of your different components in your blood. Meaning, this will lead to bone marrow failure. So, bone marrow is having a hard time producing normal white blood cells. You can end up getting abnormal white blood cells. You can end up being anemic. You can end up having problems with your platelets as well. So leukemia, when it comes down to, we think about it, it's like, in simple terms, is cancer of the components of blood. That is in the most simple form I can give it to you, right? Ultimately, all components of blood are going to be affected by leukemia. And also, again, we talked about abnormal white blood cells can also be produced. So that's what we're looking at. Now, what are the signs and symptoms? Well, you've heard me talk about before. Abnormal weight loss is always a sign of cancer, right? Abnormal weight loss, something to look out for with cancer patients. So, sweating, night sweats, weight loss, headache, fatigue. Now, what's the big key to remember with leukemia? What ends up happening with these patients is they get an enlargement, a swelling of their lymph nodes. They get a swelling, enlargement of their liver. Can also happen in the spleen and testes. Okay, and it can be painful, right? So what would you consider? Abdominal pain, testes pain, right? Pain on a lymph node, right? Bone pain, and also easily to bruise, because again, the components of the blood are being affected abnormally. So this is leukemia here, and it's what you need to know about it. So now we're on to lymphomas. Lymphomas is going to be a cancer disorder of our lymphatic system, our lymphatic tissue, our lymph tissue. So that's what we have here. Now, we're going to start with Hodgkin lymphoma. Then we'll talk about non-Hodgkin lymphoma. They're simply just names and titles. Now, Hodgkin lymphoma is a progressive enlargement of the lymphoid tissue. Remember, our lymph system is our immunity system, our defense system in the body. What this means, if we have a cancer as a type of lymphoma, like Hodgkin's lymphoma, our immune system is going to go down. Our defense is going to be depressed. So our immune system is depressed in a lymphoma. Now, confirmation, the medical team will find the presence of what's called a Reed-Sternberg cell in the lymph node or the organ as being affected by the cancer. Okay? Signs and symptoms. Swollen lymph nodes are one of the first signs that we're going to see. Fatigue, chills, night sweats. We're talking about weight loss. Could be in more severe cases, again, shortness of breath, chest discomfort, stuff like that. So that's what we're looking at here for our Hodgkin lymphoma. Now let's talk about non-Hodgkin lymphoma in the next one. So now I want to talk about non-Hodgkin lymphoma. So remember, they're just titles. It's the same idea. They're both lymphomas. They're a cancer disorder of the lymphatic tissue and system. So both Hodgkin and non-Hodgkin lymphomas are going to be immunodepressed. Right. Now, under non-Hodgkin lymphoma, there are several different types and groups under non-Hodgkin lymphomas. There's many different types. The signs and symptoms: painless swelling of liver and spleen, fever. It's typically found in older adults, and sometimes there's an increased risk factor of getting a non-Hodgkin lymphoma if you're older and or have one of the following: HIV, an autoimmune like lupus, an autoimmune like rheumatoid arthritis, exposure to radiation. So those are some things to think about. So now we're on to polycythemia, which, plant this in your head, it basically stands for thick blood. What this means, we're increasing our red blood cells in our bloodstream, leading the blood to be more thick, more viscous, right? Now, this could be a good thing. I'll explain in a moment. But for the normal person, this would be considered abnormal and not good. And I'm going to explain to you where, in one case, people actually will do this on purpose. I'll explain. So polycythemia, thick blood, is an increase in the red blood cell production, which is going to increase the red blood cell level. Okay? Now, I would say always bad would be primary polycythemia, which is usually a disorder found over 50 years old. You get signs and symptoms of dizziness, blurred vision, headache, high blood pressure, enlarged spleen. You can have red or purple skin around your feet or hands. So that is primary polycythemia. That would be a disorder, a negative thing, right? Now, secondary, if I say this person has secondary polycythemia, well, it could be naturally occurring, or you could be trying to do that to your body, I'll explain. Or it can be, well, it's secondary polycythemia and you're a heavy smoker or you have cancer and that's bad, right? So let's take care of the bad first. Heavy smokers, some cancer patients could develop a secondary polycythemia, which obviously is not good for them. In that case, they're not athletes. So now let's talk about the good that we could be as far as secondary polycythemia. Well, if you go live or you visit an area at high altitude, so high elevation was what I'm talking about, right? If you, let's say, were born at sea level, right? And I'm gonna go live in a high altitude, a high elevation area. So what's gonna happen is your body is going to respond by increasing its red blood cell production, because around you in this high altitude area, you have a decreased air pressure and a decreased oxygen in the air because you're at a higher elevation. So your body's gonna notice, okay, we don't have enough oxygen in the blood that we need. Let's increase our production of red blood cells, and so we can gather more. So here's what's gonna happen. So secondary polycythemia, let's say you're an endurance athlete, like a marathoner, or you're someone who is an elite runner. What they typically do is they'll go to train in high altitude to get a secondary polycythemia, so their body increases red blood cell production. They'll train in high altitude, athletes. And then what they will do is they will have their race or competition, usually will be at sea level. So they've been training in high altitude. They've been gathering all these extra red blood cells to gain oxygen capacity. And then they're going to go train, and then they're going to race at sea level. So now they have an advantage as soon as they step on the line, that they have a higher rate to bring in oxygen. How cool is that? So that's the good part. DIC, also known as disseminated intravascular coagulopathy, is an abnormal clotting disorder that arises due to recent pregnancy, can occur, be a complication of pregnancy, a complication of certain diseases, or a complication of trauma or injury. The signs of symptoms is bleeding, difficulty breathing, hypotension, and hyperperfusion, like shock, right? So in this case, this patient that has DIC has lost the ability to clot blood. So lost the ability of platelets, clotting factors, is an increased risk of bleeding out, of course, right? And in hospital, we'll try to give them back their platelets and clotting factors by giving them blood. Now, you may have heard of hemophilia. What hemophilia is a loss of your body to control a bleed. So essentially, every bleed becomes an uncontrolled bleed because we don't have a certain factor in our body if you are a hemophilia patient. So what this means, one, this is an inherited disorder, okay? Now, here are the two types of hemophilia. Hemophilia A is a loss of factor 8, okay? It's a Roman numeral style when they actually write it out. But I just put it here just in case you don't know it. factor 8. Okay. Hemophilia B is loss of factor 9, that's 9. Okay. Now, what happens if someone with hemophilia bleeds? Well, if it is a severe uncontrolled bleed, they would require to go to the hospital, and they would be administered the factor they're missing to make sure the bleed can stop, right? So it would involve an infusion of these factors for an uncontrolled bleed in this patient that was severe. Now, we need a word in medicine to describe a low platelet count. That word is thrombocytopenia. So here it is. It's a low platelet count, okay, which we know our clotting is going to be abnormal, right? So this occurs if the body either destroys too many platelets or the body is not producing enough platelets. Again, this is one of those things we talked about like anemia earlier, where we were saying with anemia, hey, that's a low anemia, low red blood cells. What's going on? If we see this, a low platelet count, we go, okay, what's going on? So that's a symptom. We're trying to figure out what's going on with the patient, right? Now, this could be a complication of cancer, HIV, stuff like that, for example, just to give you an idea. Now, signs and symptoms would be red, purple spots on the lower legs, prolonged bleeding that you're noticing, frequent nosebleeds, bleeding when brushing your teeth, an unusually long menstrual period. That would be some of the signs and symptoms. Toxicology is a study of poisons and toxins that enter the body that will do damage and can also change the structures even of our body, changing temperatures in the body, causing changes in vital signs. It can even be life-threatening. So this is toxicology. Now, there's 4 main routes that toxins and or poisons can enter. And please remember here that we're talking about many different facets in toxicology. There could be an accidental overdose. There can be a purposeful overdose, right? There also could be an event where there's gas in the air that is completely accidental, just environmental reason, right? So don't always tunnel vision on somebody overdosed. Yes, that is toxicology, but also there are other reasons. For example, so number 1, we have ingestion. An example I give you, let's say they were suicidal. They could overdose on prescription meds. You can also overdose on prescription meds by accident. An elderly patient could mismanage their meds. That's possible. So that's the ingestion route, ingestion. Absorption, which means basically through the skin, right? Another, you could say topical. Sure, that makes sense. It's also could be possible too, right? Obviously, if you rub nitroglycerin paste all over your body, well, that wouldn't be good, right? Or put on way too many pain patches, right? This is all possible, right? So absorption. So the one I think about is acids and alkalis, right? That can be really bad. And what about inhalation? Well, inhalation, I think of different types of gases, like, for example, nerve gases. That would be inhalation. And injection. The classic one would be your patient, they've overdosed on heroin, which would be obviously an injection through the vein. I'm going to break down for you some of the most common overdoses that you may see and what class and what types of drugs you commonly will see that patients will overdose on. So we start with opiates and opioids, and I want to show you what the effects would be, right? So you can see these clear-cut signs and symptoms on exam and go, oh, I know what that is, right? So the big thing here with opiates and opioids, right? So morphine, codeine, fentanyl, methadone, oxycodone, heroin, right? The biggest thing that they're going to cause is respiratory problems. So they're going to lower your respiratory rate, which means an adult will be under 12. Meaning you'll need to manage their airway if they've overdosed. You'll find this patient who's overdosed on opiates unresponsive with pinpoint pupils, slow heart rate, bradycardia, low blood pressure, that's hypotension. And then also the most important factor is they're either not going to be breathing at all because they're nearing arrest or in respiratory arrest, or they are breathing very, very slowly. We call that, so this is respiratory depression, hypoventilation, pinpoint pupils. They get overly sedated. That can lead to like a coma-like state. And then the next step is they're going to be in respiratory arrest. And then if you do nothing, obviously, the heart will stop, cardiac arrest. And then hypotension and bradycardia, right? So these are your main signs and symptoms. Respiratory depression, and they get overly sedated is the key. The next class of drugs that we want to look at is sympathomimetics, which, for lack of a better word, it's going to jack up, raise up your sympathetic nervous system. Now, the two drugs that are in a class of obviously illegal drugs would be cocaine and methamphetamine. So these are a sign and symptom of someone that has taken cocaine or methamphetamine. If they are overdosed on coke or methamphetamine, these signs and symptoms will be exaggerated, right? So, hypertension, tachycardia. So, high blood pressure, high heart rates. Adults over 100 with the heart rate. Dilated pupils, right? Now what else? Agitation. Also hyperthermia. What's the big key here with these patients? If your patient is using cocaine and meth, they are at risk of coronary artery problems, right? So they're at risk of having heart attack, MI, right? Because the heart is beating vigorously. The vessels are getting vasoconstricted, right? High blood pressure, high heart rate, a lot of stress in the heart. So they're at risk of having a heart attack, and prolonged use can cause that. Benzodiazepines are sedatives. These drugs treat many things in many forms. Some of these drugs we carry in the ambulance, in EMS, right? Some of them are in pill form, and they're used to treat anxiety, panic attacks, right? And then they can also, unfortunately, be used as street drugs too, right? So, benzodiazepines, they are sedatives and have hypnotic effects, which means you gotta remember the whole event, right? So sedatives, sedation, right? So we have Xanax. Now, before we get into this real quick, I've underlined the actual brand name. This is a generic name. The reason I want to include it with this is commonly you'll hear patients talk about the generic or the brand, so I just wanted to bring it up. So we have Xanax, brand name, alprazolam, generic, diazepam, and then we have Valium, right? Versed, midazolam. Remember, what I'm saying is the brand name is like the marketing drug name, like you'll see in the commercial, right? The generic name is closer, not even close to the actual chemical name, but more similar. This is a generic name you might see on the pill bottle. So I want to tell you both names. It's the same exact drug, just so you're aware. A brand and generic drug, it's the same exact drug. So just so you're aware about that. Brand and generic, it's the same thing. So Xanax, also known as alprazolam, diazepam, also known as Valium, Versed, also known as midazolam, clonazepam, also known as Klonopin, and Ativan, also known as lorazepam. Now, out of these, three of them we actually carry in the ambulance at the paramedic level, which is Ativan, Versed, and Valium. Now, these two drugs, clonazepam and Xanax, are commonly found in pill form, and they treat anxiety and panic attacks. Now, what are the signs and symptoms of somebody, on these medications or overdose on this medication? Remember, I'm giving you the effect / what happens if you overdose. So, if we actually take this drug, you could see slurred speech. They could be a little sedated. If they were to overdose, you would see hypotension, bradycardia, sedation that would turn to coma, that could turn into arrest, hypoventilation, respiratory depression. This is very similar to opiates. Very, very similar. It's benzodiazepines. One quick pearl I want to add in this video about benzos, the three that we use in EMS, so Versed, Ativan, Valium, probably, well, why do we use it? We use these drugs in EMS to actually treat seizures. We can also use it for pre-sedation as well. And also these drugs could be used as a sedation at the paramedic level for certain airway procedures. Our next class is anticholinergic drugs. If you haven't watched the pharmacology video yet in this accelerator, very simply, we have our sympathetic nervous system that brings us up, right? Increases your heart rate, increases your blood pressure, right? On the other side, we have the parasympathetic, which is more the rest. We have fight or flight sympathetic, then parasympathetic is rest and digest, right? They're always in balance with each other. Certain medications or certain patient states can change this balance where one actually shows up or the other one shows up, right? So in this case, an anticholinergic drug like atropine, what atropine actually does, it goes in the body and it blocks down the parasympathetic from working, which means the sympathetic is unopposed. So indirectly, the sympathetic's, oh, I'll take over, you're shut off. So we get this effect. So the signs and symptoms of taking too much atropine would be tachycardia, dilated pupils, dry skin, hyperthermia, hypertension. This, if you were to overdose on atropine, you would probably end up in seizures, coma, and then later arrest. So we talked about anticholinergics, now cholinergics. So cholinergic drugs are going to do a direct attack on our parasympathetic system, right? So cholinergic drugs, for example, organophosphate poisoning, and that would be your classic cholinergic overdose, and also some nerve agents and nerve gas. So there's a mnemonic here. It's called SLUDGEM. SLUDGEM. These are your signs and symptoms of a cholinergic overdose. Now, how do you think we treat this? With an anticholinergic drug, we treat, just please remember this, folks, organophosphate poisonings, we treat that with atropine. So please remember that. Okay, now, here are the signs and symptoms. Essentially, you want to think, if I give atropine, I'm going to dry up the patient. If a patient has organophosphate poisoning, you want to think that they are basically wet, if you will. So hang with me. You'll see what I'm talking about. So S is salivation, right? Sweating. See where I'm going here? Lacrimation. That's from the eyes. Okay. Urination, defecation, drooling, diarrhea. See where I'm going here with the driver's sweat? Okay, good. Gastric cramps, upset, emesis, vomiting, and muscle twitching. Those are the main signs of a cholinergic overdose. So remember that key. This class of drugs, of hallucinogens, in the name, it says it, your patient is going to be seeing hallucinations. These drugs will detach the user from reality. It will also intensify their vision and their auditory. So let's go over a few things here. Some of the main ones, and we're going to talk about this. LSD, PCP, peyote, mushrooms, ketamine, DMT. Now you may have heard me say in other videos, ketamine is a dissociative agent, right? Well, what class is under? Hallucinogens. You see where I'm going? Right. So, separates user from reality, visual hallucinations, will intensify vision and hearing. Now, if someone is, you may have heard someone have a bad trip, right? What this means, they're going to get very anxious. They're going to get hypothermia, hypertension, tachycardia, anxiety. There could also be nausea, vomiting, paranoia, right? So you may see these patients in the ambulance. Some can be anxious and calm. Others could be combative and violent. Not because of you as EMS, because they're hallucinating. And this is what's going on. And they end up being your patient because they're out in public and about and they're hallucinating. And then here we are. So treat them in a calm, professional manner. Now, our last part here with toxicology is going to be alcohol abuse. So we're going to break this down. It's a lot here. So first, we're talking about a chronic alcohol user patient, right? That's what we're looking at. So someone that is abusing alcohol and what they might call 911 for, or what might develop, what you might see in your patient. Now, I'm going to break this board down, and then we're going to talk a little bit. So let's first break the board down. So alcohol abuse. Alcohol has both sedative and hypnotic properties. So hypnotic means to induce sleep. Sedative, obviously sedation, makes me relaxed, right? Alcohol will dull your reaction time, really will dull your overall awareness situationally, and also slow your reflexes. Now, this is key, and I teach this to all my students. Do not get tunnel vision with alcoholic patients. If someone calls the ambulance just simply because they drank too much, or they appear to be an alcoholic, or they tell you they're an alcoholic, do not get tunnel vision just assuming, oh yeah, it's just an alcohol problem, no big deal. That is completely wrong, and you will get burned, because I've seen people in EMS get burned that way. I don't want it to be you. There have been cases throughout my career where literally because I didn't have tunnel vision, I was able to help a patient that was actually in real distress multiple times. where someone else might have thought, oh, no big deal. So I want you to be on the good side of this. Now listen up. Alcoholic patients, as we know, they can lack coordination if you drink too much, right? So what does this mean? They could be victims of other medical emergencies. The second part is, what about trauma and traumatic emergencies? Someone who lacks coordination can also have a head injury. Someone that lacks coordination could have a low or high blood glucose. Someone that lacks coordination could be having a stroke. You see where I'm going with this? So we always assess these things. Now here's what I wrote down for you here. Always perform a full assessment. Get vital signs. At the very minimum, check pupils, check for head trauma, ask if they've been assaulted, do a head-to-toe exam, get vitals and a blood glucose at minimum, okay? And do your assessment. So I wrote here, BGL is blood glucose level. If you didn't know, get a blood glucose level. And do a full trauma assessment. Do a head-to-toe on the patient. Now, next, the patient, of course, could be nauseous, could be vomiting. Yes, I got a new word for you here we've never talked about in this course yet, called hemoptysis. So let's break it down. Hema has to do with blood. Emesis, if I take away the hema, emesis means you're just throwing up. Hemoptysis means you're throwing up blood. So hema is blood. So with patients with alcohol, if you're chronically, let's say you're drinking every day 4 years, right? You will irritate your stomach, and that can cause bleeding or GI bleeds, upper GI bleeds in your stomach. So alcoholics could throw up blood. It's common to see that when they're nauseous or vomiting. Don't be alarmed by that. It's obviously not good, but that is what can happen to alcoholics. You know about that, right? You're not going to be surprised where that comes from. Now we know. So what is this withdrawal symptoms? So let's just break this down. Delirium tremens, also known as the DTs, okay, is really frightening hallucinations from someone who is withdrawing off of alcohol, right? So it's alcohol withdrawal with hallucinations. Alcohol withdrawal looks like this: agitation, fever, nausea, vomiting, tremors, seizure activity, altered mental status or confusion, right? Now, what is a test that you can do to see if your patient is actively going through alcohol withdrawal? Now, I can shake my hands like this, right? And I could just be frightened, right? I could be shaking, I could have anxiety, right? This is like I'm exaggerating a little bit, but you get the point. Obviously, I'm not really doing this. I'm faking this, right? So, the one part of the body that we cannot, basically shake like this with a tremor, it's involuntary, is our tongue. So I have a test. I learned this from a doctor earlier in my career in hospital when I brought in an alcohol withdrawal patient. He walks in the room and he goes, hey, can you open your mouth? Stick your tongue out. And the tongue was moving like crazy. Like almost the patient's tongue was having a seizure. And I go, what was that for? He goes, I call it the DT's test. And I'm like, I'm going to use that on my students. So that is the DT's test, and I hope you enjoyed that. Behavioral health emergencies, remember this, folks, can happen to anyone because some mental health crisis can be temporary or situational, but that doesn't mean they can't arise to a level where the event is so strong in someone's life that it becomes either a crisis or emergency. And I'm break that down and talk to you about that right now. So remember, you're going to be dealing with behavioral health patients, people going through situations, for example, could be death of a spouse, death of a loved one, divorce, right? That's a situation where you could have a behavioral crisis or behavioral emergency, but the person is not diagnosed with any psychiatric disorder, but a temporary situation has caused the event, and now you're there dealing with them. Yes, on the other side, you will see and you will deal with patients who have diagnosed psychiatric disorders, whether they're violent or non-violent. It is a myth that all psychiatric patients are violent. That is not true. But as EMS, you will be exposed by default because we are first responders to more of them. So we need to know how to deal with them when it arises. Okay? And remembering, a lot of the times, a lot is out of the patient's control. We're going to talk about that later on. So let me just go through some key terms here. So behavioral crisis essentially means that the patient is in danger of being violent towards others or themselves. Okay? So again, hurting themselves or others. A behavioral health emergency is when we cross that line into, no, they are right now 100% action has been taken and they are hurting themselves or others. And that's a lot of times when this becomes an emergency, we're called, right? And we're going to talk about even more as we go along. Again, folks, you will encounter both situational mental health crisis and patients with diagnosed psychiatric disorders. So we talked about behavioral health emergencies. First, I just want to give you some guidelines when dealing with a mental health patient. So here's what we have. So first, law enforcement should have the scene secured before you get there. So when you go to this call, dispatch should have law dispatch with you. They should already be on the scene and have the scene safe. You should not be entering by yourself. And of course, if dispatch says stage, then you stage, right? So law should be securing the scene prior to your arrival. Next here, you want to make sure you have your radio on you. Now, I'm going to show you something here. I'm going to walk over here and grab my scope. So, you don't want to walk onto a scene with a potentially violent patient with your scope like this, because it can be used against you, right? Same with your shears. You don't want your shears hanging out of your pocket, right? So all this equipment should be tucked, put away. Same with the shears. You want to have everything free. You don't want to have this around your neck. So that's one of the big things as far as EMS. Let's go ahead and put this back. But that was a quick tip I want to share with you. Same thing with like a hoodie, right? You don't want that to be pulled over you. So just some quick tips as far as potentially violent patients. So next, you want to know all your exits. Make sure you have your ambulance stage where you can just go forward without having to back up or turn over. That's pretty important. You want to be direct, honest, and calm with the patient. You don't want to be overbearing. You don't want to stand over them. If they're on the floor, you don't want to stand over them like this. You want to get down to their level, but provide some distance. So that's the big key. You don't want to be overbearing. Remember, you're on their team. You're on their side. You're a healthcare provider. So you're on their team. So this is very important. You're there to help them get through this crisis they're in. So you want to remember that, I guess you could say, motto going into the call. And these are 3 words that I wrote down of how to best deal with a behavioral health patient is be direct, be honest, and remain calm. And no matter what chaos is going on, remember, everyone's looking to you, the EMT, the paramedic, to be calm. So please remember that. Now, our first disorder is schizophrenia. Now, with schizophrenia, the onset is early adulthood. It's usually around 16 to 30. Now, this is a lifelong psychiatric disorder, and it involves lifelong therapy. The issue with this lifelong therapy, and a telltale sign of schizophrenia, is they may have tremors in their hands due to the medication use over time. That's a side effect of it that can be chronic. Now, what are the signs and symptoms? Okay, delusions. Now, delusions, the definition of a delusion is a false belief. So, a patient with schizophrenia may hold beliefs inside them that are completely false, but they believe it so much, they know it to be true, but it's false. Paranoia, obviously, is extreme worry. Flat affect is just basically just a straight across the affect. There's no high, there's no low, it is just straight across, right? And the way someone speaks. Cognitive challenges can occur with schizophrenia. Not everybody with schizophrenia, but it is possible, okay? Erratic speech, and then hallucinations. So hallucinations is obviously seeing or hearing things that are not actually there. But to the patient, it seems 100% real. That's a hallucination, right? Now, what are some of the most common medications that you will see on a patient's med list with schizophrenia? Well, here they are. Latuda, Haldol, Geodon, Clozapine, Seroquel, Zyprexa, Risperidone, Thorazine. Okay? So, these are some of the main medications you'll see that if they're on that medication, you could pick up on it. Now, just be aware. These medications, okay, I'll give you an example. Seroquel. Seroquel can also be used to treat bipolar disorder and schizophrenia. So, Just because someone's on one of these medications doesn't mean they have schizophrenia 100%. It's possible. All these treat it, but someone can also be on therapy with bipolar. We're going to talk about bipolar in a little bit. So that's what we have for schizophrenia. Moving on to delirium. Now, delirium is a abrupt change. So I'll read it to you here. An abrupt disorientation of time and place that involves delusions, hallucinations. Remember these, they're key terms. Delusions, false beliefs, hallucinations, sights or sounds that are not present. So that's delirium. Then we're going to talk about delirium versus dementia in a little bit. So hang with me for that. Now, the big key here is excited delirium. So right off the bat, excited delirium is a life-threatening emergency. At the EMT level, you may very well call ALS for this call. You're definitely going to be going like inside to the hospital with someone with excited delirium. Now hang with me. Let's go through all this. So excited delirium and underlined head trauma. I'll tell you why. Excited delirium can be caused by substances, psychiatric illness, or head trauma. What this means. You can have a patient who has head trauma and now they're in a state of excited delirium, which is they're in a life-threatening, abrupt disorientation of time and place, and they have these, right here, the last piece, have these life-threatening signs and symptoms. Panic, paranoia, agitation, ranting, they may be violent, right? Hyperactivity, and then they may be diaphoretic. What happened? Why is life-threatening? Hyperthermia. So the patient actually becomes hyperthermic. So I started this for you to remember this. There's two stars here. One, treat for hyperthermia. Keep the patient cool. That's at the BLS level. Now, what may a paramedic do? Well, first off, because this patient's in excited delirium, for example, due to, let's say it was via head trauma, they may be so agitated and violent, you're unable to transport. Law enforcement's there because this patient's so violent and agitated, but they are going through in this case, a traumatic and medical emergency, right? So in order to actually get them to transport, you may need to sedate the patient. So this is a big, big one here. And I'll never forget, as a side note, the first time I had a traumatic excited delirium call, and exactly what we had to do was actually go and sedate the patient to facilitate transport, to rescue that patient and get them out of that scene. So that's what we're looking at here. Big one, excited delirium. So coming off delusions, I want to talk about dementia. So a lot of people talk about delirium versus dementia. So here's the key to remember. Delirium is an abrupt disorientation of time and place. It happens fast. Dementia is progressive and slow, right? So delirium is acute, happens like right now. Like I'd be normal, now I'm delirious. Dementia is a progressive disease. It's over usually years' time, okay? So that's the biggest difference between dementia, right? Now, going on to bipolar disorder, okay? The biggest thing with bipolar disorder, it's an emotional disorder, and you're going to alternate between depressive and manic episodes. Now, depression, I'm going to go over here in the next piece so we can kind of see the difference. The most common med for bipolar disorder is lithium. Now, what exactly is mania? So here are the main signs and symptoms. Excessive ideas, or they call it a flight of ideas, motor activity, fast speech, basically extreme talkativeness, irritability, and also possible delusions. So possible, again, false beliefs, that's delusions. So these two. I want to move on and talk about depression next so we can kind of tie it in together with bipolar. There is a mnemonic called In Sad Cages that actually gives you, as the provider, all the signs and symptoms of depression so to remember it. So here it is. The first is loss of interest, IN, in activities. S is for sleep disturbance. A is for appetite change. D for depressed mood. Then we're going to move on here, okay? Now, caution, watch this. So, cages. Difficulty concentrating. Activity level change, there's your A. Excessive guilt, your G. Loss of energy, your E. And suicidal thoughts, your S. So if you remember Inside Cages, you'll never forget depression. So what I have here, I put together a list, just some of the common drugs that you may see for someone who's suffering from anxiety or panic attacks. And then the other side would be dual. It could be anxiety or depression. I'll explain as we go along. So here I have the brand name. Remember, the brand name is like the marketing name of the drug. And then on the other side is a generic name. Remember, the brand and the generic name is just a name. It's the same drug, except one has a marketing name on it and one's a generic. It's the same drug, same thing. Okay, so Xanax, also known as alprazolam, Ativan, also known as lorazepam, Klonopin, also known as clonazepam. These treat acute anxiety states like anxiety and panic attacks. Now, these drugs right here are called SSRIs, which has an action on the serotonin levels in your brain. These three medications are very commonly prescribed for anxiety and or depression or a combination of both. Okay, Celexa, Zoloft, and then Lexapro. Now, I've added this drug here because I call it a wild card. This medication I've seen in so many different patients used for so many different reasons. So Abilify, here's a generic name. I've seen it used schizophrenic patients, bipolar patients, depression patients, and even other disorders as an option when other things haven't worked. So if you see Abilify, it could be any of many different other things we talked about in this call, just to keep an awareness on that. I want to include a few points here about suicide and suicidal threats and suicidal ideations. You may hear that, ideas. So it's usually a call for help. Remember, this is the key. We talked about this, remember earlier on. A patient can be suicidal due to a psychiatric disorder or a temporary crisis going on in their life. Remember that, please. Okay, now, determine if there is a plan. There's three main keys. So first, determine if there is actually a plan for this potential suicide. Seeing the scene environment, does it appear that the patient has the means? And then finally, do they intend to be successful? Right? Now, to someone who's a new provider, that may sound, well, when they tend to be, that they want to be successful, again, this is usually a call for help. So the patient may, if it happened to me, will tell you, and they will say, hey, I wasn't actually going to do it, but I didn't have a choice. I need help in this area. So that's something very important to look at. Now, here are some keys, and this may sound, basic, but this is what actually needs to be done in this call. So support the patient. Don't make a bunch of statements yourself. Okay? You're going to ask about these things, and then all you're going to do is get your vitals, support the patient, listen to them, be there for them, ask them about any support systems they may have in their life, and then transport. Simple as that. I want to talk about autism. Autism is also known as, you might see on a medical sheet, ASD. So, two keys, and then some points, some signs and symptoms I want to talk about. So first is they have some impaired social communication. That's the first key. So social communication is impaired. The social skills are impaired. They're not at the level they should be. Number two, there's restricted or repetitive behavior noticed. Symptoms usually begin to be seen around 18 months, but they usually aren't picked up at that point. Later, slowly but surely, you may have seen it. Then the parents and the parents' doctor start to kind of pick up on these signs and symptoms. Some children may engage in self-harm behaviors as well. So this is key. Remember, with autism, there's a spectrum on where they're at, and this can determine a lot of these. It can be minor, some more major. So if we're going to scroll down here, this is a big point I wanted to write on the board for you too. Autism patients, especially when they're children, can be at a higher risk of traumatic emergencies, falls, walking in front of cars, etc., etc. They're at a higher risk because their social communication skills are not at the level they're supposed to be. They are considered poor, right? So they can be caught up in some of the situations. Now, signs, symptoms. I have a lot here. I'm just going to back up just so I can read them to you here. So avoids eye contact, can't explain what they want, repeats words, doesn't engage in play, not responsive to others. And also, this is big, some can be nonverbal and or there's delays as far as their speech. Now we're getting into talking about patients who are combative, aggressive, violent, and they are a danger to hurting themselves, others, the public, bystanders, providers, and you've been called to transport this patient. Now, I want to share something with you. This is called an emergency detention. In slang terms in EMS, it's called a patient who is getting papered, right? You may have heard that term. I just want to share it with you here. Now, what this means, in every town, city, region, country, area, it's different. But what this means, either a law enforcement, like a police officer, or a psychiatric doctor has filled out a form that includes they have to be transported to emergency departments for mental health. And they are not, the patient is not of sound mind, and they're a danger to themselves or others, so they must be transported. This is what's out there. Now, just because we have a psychiatric doctor or law saying they're not of sound mind, we do not get tunnel vision. We still do our assessment. I recommend doing the best you can to gain the following: vitals and assessments of blood glucose. Now, I'm going to walk you through a scenario here, and we're going to do it together, okay? But that's the goal. Don't get tunnel vision. So try to look for head trauma. Now, again, these patients are being violent. These patients are being combative. They're not of sound mind. For example, someone can have head trauma and be in excited delirium. They don't know what's going on. Someone with schizophrenia could be having an event, right? These are all possibilities, right? Now, here's the system I have, and what we're talking about here is getting to the point from basically the easiest behavioral emergency transport down to the hardest. So imagine you're the patient, you're not of sound mind, and imagine someone tells you, you have to go to the emergency department. You have to go, right? You're not of sound mind, you're the patient. Put yourself in the patient's shoes, you're altered. You have to go to hospital, right? You got law enforcement, EMS, psychiatric doctor, maybe some friends or not friends, but maybe some family, right, on scene with you. This is all happening very quickly, a lot of people, while you're having this aggressive episode, right? How do we get this patient to get onto the stretcher and transport into the ambulance? Well, here's the system I have. First, find the patient support system if they're on scene. Try to get them to speak with the patient and say, look, there's no other choice, you have to be transported. We try that. Secondly, we introduce EMS and then law enforcement individually and try to speak with the patient. If these all fail, just remember, law enforcement will be on scene and already have talked to the patient. This is their second time seeing the patient, right? So, but we try them, doesn't work. Try one final time with this patient before you do restraints. So 1, 2, 3, it's like 4 times. And this is all, again, this is not on a rule. I'm giving you from like street experience, like how this has handled and what I've done. Okay. Because obviously every paramedic has had a chemically restrained. And then we have calls where, the patient's, mother or the patient's daughter or family member or friend is able to speak with them and they just come in the ambulance and they go because they understand, okay, I have to go, right? Restraints. I'm going to talk about how to do restraints in the next, board here in a minute. Restrain the patient. If the patient is either extremely difficult to restrain, like meaning they're forcibly coming out of the restraints, right? They're fighting. They're still worked up even while being restrained, or they continue to hurt themselves, possibly while the act of restraining, or I'll give you an example. So let's just say the patient's restrained. In some ambulances, they could, and I've had this unfortunately happen, the patient can go like this and still hit their head against the cabinets, right? If they're restrained, or they're bucking the stretcher while you're moving, stuff like that, right? That's what you want to look for. This may be a time for chemical restraint. The patient also is very difficult to restrain, and they're being violent, right, with staff or bystanders from the start. There's and the patient is not of sound mind whatsoever. They're not even speaking with you. You might have to go with chemical restraints, right? So that's the key here. I want you to be aware of this. Now let's talk about the process of actually doing the restraint. So moving into actually using the restraints, just some keys I want to talk about. We never place a patient prone, meaning on their stomach on the stretcher. We never do that. The reason why is that can compromise their breathing and or their heart and blood pressure. So when you restrain a patient, they should be on their back, supine. That is a key. You could also bring the stretcher up or the bed a little bit to restrain the patient. Both will work, right? But they're on their back. Supine position, for example. Okay? Next, if a patient still struggles forcefully, after restraining, now what does that look like? Well, if the patient's restrained, I'll give you an example. In some ambulances, they may have enough room to actually hit their head, or from experience, take their head and move like this, and strike, and actually still hurt themselves by striking their head against the cabinets, right? The other thing is, if they're using so much energy because of the crisis that they're in, I mentioned one earlier. So for example, let's say someone has head trauma due to excited delirium, and to transport this patient, they're having a life-threatening medical and traumatic emergency, but they're so aggressive. They're not of sound mind because they're in excited delirium. They have a head injury. We need to treat them. Let's say you restrain the patient, but they're still forcefully moving on the stretcher. We need to care for the patient. And not only that, the patient's doing harm to themselves by forcefully moving like this, all this energy. They're gonna pass out, right? It's not going to help the patient, right? So, especially when they're having a medical or traumatic emergency. So this is where chemical restraints can come in. Now, chemical restraints is giving a sedative to sedate the patient. That is a paramedic level thing. Now, before this, about being in the restraints, well, let's go back even more. What if you literally cannot even restrain the patient? That's where chemical restraints come in, right? Essentially, the reason why we do restraints and or chemical restraints is because the patient is not of sound mind and they're hurting others and are hurting themselves. And we got to put ourselves on the spot and go, okay, if I was in excited delirium, would I want someone to abandon me, or would I want someone to, yes, sedate me and care for me so I can continue to live? Because I don't know what's going on. I'm in excited delirium. See where I'm going with this? That's the key. That's why we're here, the EMS. So that's what you want to look at. Now, here's another point I didn't mention yet. You wanted to brief the family and friends on scene, or staff or other bystanders that are, with the patient before you actually go and restrain. So they know what's going on. So they don't see you restraining, but what's going on? You want to debrief first and then go forward. And remember the plan of action I talked about on the slide before this. I would say like falls and abdominal pain, call in the ambulance is very, very common. This is one of the most common calls you'll go to. So we got to be good at this. So let's talk about this. Abdominal pain. So these are some of the main signs and symptoms that accompany abdominal pain. Nausea, vomiting, constipation, diarrhea, chills and fever, change in their stool color. Those are some of those common signs and symptoms right here that accompany and go with abdominal pain. Now, I have a list here, and I also have pregnant, and I have heart. Why did I write all this down? And I put diabetes. Why did I write all this down? Let me share with you why. You go to someone who says, my stomach hurts. I have abdominal pain. It could be any quadrant, right? You want to ask them about this list. So someone has abdominal pain. You want to ask, are you nauseous? Have you thrown up at all? If they're throwing up, what color are they throwing up? Is it more blood or vomit, right? Constipation versus diarrhea, right? Constipated, well, there could be a blockage, dehydration. Diarrhea, is there some infection, right? See where I'm going here? Changing stool color, again, is it like dark stool? Could it be blood in their stool, right? See where I'm going with this? Chills and fever, right? More infection, inflammation, right? Is there any chance that they could be pregnant, right? So we think about ectopic pregnancy, right? See where I'm going with this? And then don't forget about the heart. The heart is sneaky. The heart is very sneaky. So you got to remember that sometimes heart attacks can present atypical, right? Especially in diabetics, female patients, and also elderly patients. Heart attacks can present as, oh, I got pain right here in my stomach. So don't forget that, right? And I honestly don't want you to forget about this. With diabetics, what does diabetes have to do with? The pancreas, right? So don't forget, a diabetic, abdominal pain, they could have some sort of pancreatitis going on. There could be something else going on with the pancreas. So never forget about that as well. So this is our first kind of look at how we're working up an abdominal pain. Now, what I've done here, I want to share with you one of the greatest mnemonics I've seen. It's called bad gut pains. Bad gut pains is a mnemonic. BADGUTPAINS. Bad gut pains. This mnemonic is for you to critically think about, okay, they had abdominal pain. What might it be? I don't want you to get burned on a patient case, because you are not understanding and thinking critically about what it might be. So the first one, I got you thinking about some odd things. Could it be ectopic pregnancy? Could it be their heart? Now I'll go a little farther. So B is for bowel obstruction. Remember, the bowel also means large intestine. So is their large intestine blocked? Appendicitis. Do we have an infected and inflamed appendix? Diverticulitis is little pockets in the colon that are being infected, right? Little holes in the colon that are being infected. DKA, diabetic ketoacidosis, right? That goes with your high blood glucose level. Now here I put gastro/gallbladder. You'll see I did a little twist on this, but to get the best out of this for EMS. So gastro and gallbladder. So think stomach and gallbladder. Could there be something wrong with those organs? Urinary. Could it be like a kidney stone, or could it be a UTI, like an infection? Could it be something wrong with the testicles, like a torsion, or could it be a toxin going on? I got a toxin in the body. That's why I have stomach pain, right? Pancreatitis, and then pregnant. Never forget. Could it be an ectopic pregnancy? Right. That's why I put pregnant. Whoa, that's a life threat. Say another life threat is a AAA. So your abdominal aneurysm, AAA. Okay. Then we have infarcted bowel. Could it be IBD? We'll talk about that later. Inflammatory bowel disease. And then could it be a splenic injury, like a splenic rupture or enlarged spleen, right? We're talking about splenic injury. Also, sickle cell crisis. Don't forget about that. It causes immense pain. So this gets us, the first two boards here, everyone, gets in the right thinking for, okay, it's abdominal pain, but let's go a little deeper. So now I want to talk about GI bleeds. So we have an upper GI bleed and a lower GI bleed. Upper GI bleeds, we commonly think about the esophagus and the stomach, maybe the beginning portion of the intestines, or we think of like the colon, aka large intestine, and then, obviously the rectal area, and we're talking about lower GI bleeds, and we'll talk more about lower in a minute. So here's upper. So upper GI bleeding. Now, what can make upper GI bleeding worse? NSAIDs, blood thinners, of course, right? Now, what are some of the main causes? So gastric or duodenal ulcers, esophageal varices. We can have an inflammation of the stomach or inflammation of the esophagus. Now, what is Mallory-Weiss syndrome? Now, Mallory-Weiss syndrome, what that is someone who's repeatedly vomiting a lot, all the time. So it could be a bulimic patient or an alcoholism patient that are commonly typical. What will happen is they'll get deep tears in the esophagus that can cause bleeding. So that's Mallory-Weiss syndrome. Now, of course, blood in the vomit would be the main sign and symptom. Then obviously we look at red or dark like coffee ground like appearance to the bleeding. That is going to be indicative of an upper GI bleed. Now let's discuss lower GI bleeds. So with a lower GI bleed, here are the causes. Diverticulitis, diverticulosis. We're going to talk about that as we go along. Colon cancer or colon polyps, right? Which we'll talk about as we go along. IBDs. We'll talk about that as we go along. Inflammatory bowel disease. We're going to talk about that. Those are some of your causes. Now, what are the signs and symptoms? Cramp-like abdominal pain, changes in the stool color, changes in bowel habits is actually one of the first signs of colon cancer, if you didn't know that. Diarrhea, and then nausea and vomiting. So those are some of our signs and symptoms. Of course, with any bleed, if you're on, I ain't right here, but if you're on a blood thinner medication like anticoagulants, we have that in prescription medications mastery to make sure to check it out too down in this course. To know your blood thinners, your anticoagulants. Of course, that's going to make any bleeding event worse. That includes this kind of bleeding. So there it is. So we look at stool color changes. Do not be tripped up by this. Hear me on this. If we have bright red stool, we usually think that's something more lower as far as a lower GI bleed because the blood is fresh. It's bright red, right? Meaning it's probably closer to the rectal opening. Now, that would constitute more lower thinking, right? Right. Now, I would say this. The more darker the stool, meaning let's say it's a black or a tarry colored stool, right? So like a black stool, you tend to think it's more upper GI, or at least think it has the potential to be upper GI because that black stool, it's not bright red, fresh blood. What it is, it's partially digested blood. Exactly. So bright red stool we think occurs closer to the rectal opening. It's probably, if we're going to guess, probably more lower. Dark tarry stool is the medical term for it here. We think as more upper GI or the potential to be upper GI because, well, it's been partially digested. That's why it's so dark. So we think the more bright red, most likely it's lower GI. That's stool color changes. I just want to make sure that was clear so you understand that. Don't get tripped up. Now, gastroenteritis is inflammation and infection of the stomach and intestines. Most commonly, this is caused by infected food or contaminated water. Now, with this being said, okay, talking about the fecal-oral route, Salmonella norovirus is most common with these infections. And you can have, of course, from like, let's say, food poisoning route, contaminated water route, this acutely, right, like abrupt vomiting, nausea, vomiting, diarrhea, or a patient can have this chronically because they have an imbalance with their stomach and intestine. So now we're going to talk about IBDs, inflammatory bowel disease. This is broken up into two different diseases, ulcerative colitis and Crohn's disease. Here we go. Crohn's disease, ulcerative colitis. Now, we have chronic inflammation of the GI tract. This is the main hallmark of our IBDs, right? Now, let's start with ulcerative colitis. This affects the large intestine, and it is an ulceration. What's an ulcer? Let's talk about it. Anytime you hear someone say an ulcer, it's a sore, it's a painful sore of the area we're talking about. So if I say, oh, I have an ulcer, you must have a painful sore. Well, where is this painful sore? Well, this painful sore is in the large intestine, in the lining of the mucosa, the lining of the tract of the large intestine. Ouch. There it is. So because I have this ulcer, what are my signs and symptoms? Abdominal pain, weight loss, bloody stool with diarrhea, again, bleeding, diarrhea. This is the common finding of ulcerative colitis because of that sore, that ulcer, right? The ulceration. It's in the name. Ulcerative colitis. I have ulcers in my large intestine. Remember, when I say large intestine and colon, I mean it's an interchangeable word. Okay, so remember that. Crohn's disease. Crohn's disease is either small intestine and or large intestine. It can affect the small intestine. It can also affect the large intestine. It can affect both. Now, some say that Crohn's disease is autoimmune. Sure. Some say it's family related, genetic related. Sure. Okay. So we can all agree that it's a disease that has chronic inflammation. But you'll hear doctors talk about that. And there's always new things about Crohn's disease that people are learning as far as treatments and everything else. So here's what Crohn's disease is going to do. So let's say we have a normal, healthy intestine, right? Everything's going through smooth, no issues. When we have Crohn's disease, we have a thickening, an inflammation, and we have a swelling of the actual passage of the intestine. So what happens is the wall thickens, and at the same time, because it's so swollen, the passage narrows, which can lead to blocks. So this is why Crohn's disease is so bad and why there's hospitalizations, medications, stuff like that. Signs and symptoms are called like attacks. I have it written here. So frequent attacks would be diarrhea, nausea, vomiting, chills, abdominal pain, fever, and then weight loss. If you didn't notice here, weight loss seems to be a sinister sign with these IBDs. There it is. So now we're going to talk about diverticulosis, diverticulitis, and what diverticula is. So let's start from the start. What are these pouches and sacs? Diverticula is the pouches and sacs themselves that are present in the large intestine and colon in the patient. Now, when they start to get worse, we call this diverticulosis. So these are multiple sacs and pouches that are developed in the lining of the colon. And they usually are found over in the sigmoid colon. That is usually the main spot of diverticulosis, right? Now, this is a very common finding with older adults with low fiber diets. And remember, what this is, we have a normal lining of our colon. There's no sacs and pouches or weak spots. This is what we're getting with diverticulosis. Little sacs, little pouches and weak spots. What can happen is when feces is going through, obviously the bacteria in the feces gets stuck in these pouches or inside of them, and it can become infected. And basically you have an infection inside your colon. That's diverticulitis, right? Now, common in older adults with low fiber diets. Actually, the majority of people, let's say the majority of Americans, have a low fiber diet. So a tip would be to increase the fiber in your diet to do the best you can to avoid this, right? Talk about the common site, talk about what diverticulitis is. Now, what are the signs and symptoms? So change in bowel habits. May it be diarrhea, may it be constipation. That can actually prevent either way. Fever, nausea, vomiting. There could be some vomiting because you're nauseous, but really more nausea, fever, and then abdominal pain. This is pretty severe. So I want to make a quick note about peptic ulcer disease. So you may have heard about, I got ulcers in my stomach, right? So what this means, we know an ulcer is a sore of the area we're talking about. So these are sores, irritations in the lining of the stomach, right? But why they happen? Well, here's why. When we eat food normally, what happens? Food goes to our stomach. Well, the stomach's highly acidic, so it breaks down the food and it moves on. Right? Great. And then, wouldn't it just burn a hole through the stomach? No. Because we have mucus production, it protects in the mucosal layer of the mucus, it protects the stomach, right? If we have infection in the stomach and or we have poor mucus production in the stomach can't protect itself. So what happens? This. Peptic ulcer disease, and you get ulcers in your stomach. So, this is peptic ulcer disease. You may hear it in your patients, I have an ulcer. They're talking about this. Now, what a bowel obstruction is a blockage of the intestinal lumen itself. So essentially, there's a blockage in the intestine. So we're not having fecal matter actually moving through the intestine. It's blocked. Now, could it be from the fecal impaction, meaning that the feces is not moving and it's stuck? Yes, it could be. What else could it be from? Well, tumors. If we have a tumor in our way or a narrowing of the passage, that can cause a blockage, right? We talk about a lot of the inflammatory bowel diseases, right? Also, a bowel that isn't working properly. So if a bowel isn't moving the fecal matter forward, then it won't move forward. Also, a hernia, which could be the movement or protrusion of different organs, right? So this is why they occur. Now, signs and symptoms: nausea, vomiting, constipation, abdominal pain, diarrhea, and then also the big one is abdominal distension. So distended abdomen that's abnormal for the patient. Pancreatitis is inflammation of the pancreas. So here's what we have. Signs and symptoms: severe epigastric pain. Remember, the pancreas lies just behind the stomach. So if we have an inflamed pancreas, we're going to have, I got pain over my stomach, right? Remember, epigastric pain, it's pain over the stomach. Nausea, vomiting, abdominal tenderness, and also distension of the abdomen as well. Now, pain can also radiate from the stomach through to the back and even up to the shoulders. So it can go straight through. Pain radiates stomach to the back. Now, this right here, cholecystitis. What is this? Inflammation of the gallbladder, okay? Now, a common finding with cholecystitis is that there are gallstones present, which is causing a blockage in the gallbladder. Now, with cholecystitis, we have right upper quadrant pain, epigastric pain, fever. I'm going to show you something cool in a minute. Nausea, vomiting. Now, what's this? Here's the cool thing. It's called Murphy sign. Take your hand. You're going to place it right over the right upper quadrant. Have your patient take in a deep breath. And if there's pain right over your hand, over the right upper quadrant at this time, at that point, you can say it's positive Murphy's. So the positive pain increases over your hand, that's going to be positive Murphy's sign. What it is it's positive pain or worsening of the pain when taking a deep breath on inspiration right over where your hand is over the right upper quadrant. There it is. Lifespan development takes you through the entire lifespan of a human. So I'm going to take you through that right now. So let's get into it. So the neonatal birth weight, your birth weight is about 6 to 8 pounds. The head accounts for 25% of that weight. Now you may have heard about fontanelles. What's that all about? So the cranium when you're born isn't completely fused. So there's these areas called fontanelles, which is flexible tissue that is right on the edges of your cranium. Your cranium will fuse as you get a little bit older. Certain fontanelles at 9 months, at 18 months will start to fuse together. But in a, neonate, in a infant, this is great feedback for us. Here's why. If we see a normal fontanelle, great. It should be, smooth and flat. If it's depressed, that can be dehydration. If the fontanelle is bulging, that can be head trauma, like a sign of increased intracranial pressure. So these are common test questions that you'll see, and this is great feedback for you. Now with infants, their main communication is going to be crying. So what this means, crying can signal what is wrong. Now when I talk to you in this course about how parents understand their children, what I mean by that is this. They're with them, in some cases 24/7. So what this means is they are very astute to the different cries they may have and their normal activity based upon what they want and need because they're with them. So that's where I'm going with this. Now, a few key terms. First, secure attachment. Secure attachment means the infant understanding the parents and or caregivers will take care of their needs. That's secure attachment, right? Now, separation anxiety comes from fear of unfamiliar people and or places. Also comes from being away from the parent or caregiver, right? This is normal in the infants. Now, there's something called trust versus mistrust. This occurs from birth to about 18 months, where children learn if parents can provide a safe environment for them, okay? Where secure attachment talks about, will they care for their needs? Will there be a safe home environment? Will it be a stable environment? That's trust versus mistrust. So even as early as 18 months, infants can pick up on these things in their surroundings, and they'll have a feeling of, I'm in a stable, secure home, or I'm not. My needs are being met, or I'm not. This can cause problems later on in life, whether it's good or bad. That's what we talk about with children you hear so often. Have a safe, secure environment for them. There it is. So reviewing toddlers and preschool-aged children, here's what we have. So toddlers, preschool-aged children start to interact with other children and pick up illnesses, which gives them acquired immunity. So you're going to find, the infant is primarily alone. When we think about, even younger neonate, they're going to be at home. They're not going to be with other children. We get to the toddler stage, preschool age. Now, that's where we have a lot of these pediatric illnesses that we talked about, right? So now, running, walking, throwing, catching, jumping at preschool age, we have to be able to do all those things around 3 to 6 years. Toilet training, usually about 18 to 30 months. Then the actual preschool age is where you have your greatest language skill acquisition as a person at 3 to 6 years old. Now with school-aged children, about 6 to 12 years old, there's a few key terms here I want to go over. First is pre-conventional reasoning. This is reasoning based on external factors, such as a parent disciplining. Punishment versus incentive. So I'm going to go through these and we'll talk a little bit here. Conventional reasoning is more motivated by the approval of peers and society. Post-conventional reasoning is internal moral compass. They have their own instinct. There's also a development of self-concept and self-esteem. Self-concept is perception of ourselves. Self-esteem is how we feel about ourselves and how we fit in with peers. Now, here is the pearl. When we go from 6 to 12, we start with pre-conventional, then conventional, and then post-conventional reasoning. We slide like this, right? Different people will go through faster than others. Now, with pre-conventional, if I am at that level of reasoning, I'm going to base I'm going to make a decision. What am I going to do? Okay. I'm basing that decision based upon external factors like, is this, when I've done this in the past, did I get rewarded or did I get punished? That's what we're looking at, right? And then we'll make a decision, okay? Conventional is more motivated by what society thinks of me, what my peers would think of me if I did this, based upon what we've seen in the past. Post-conventional reasoning, this has to do with now, like closer to what more adults do. We have a moral code, a moral compass. We go with our gut. This is what we're talking about here with post-conventional. We have an internal code. No one needs to tell us what's right or wrong. We we start to develop an internalized code in us. That's more closer to the deal we get later on, 10, 11, 12 years. So that's what we have here. That's 6-12. Adolescents are 12 to 18 years old. Here are some key things. Vital signs level off to that of an adult around this age. Puberty begins at this stage. They're usually more concerned with physical appearance and their peers and being able to fit in. Now, there's around 14 to 16 is usually the age where risk-taking behavior and finding their own identity is just super, super important to them at that age. And it can be all to the high school ages. Now, by the end of this adolescence, around 18 years old, they have found a code of ethics. And this usually is a combination between their peer experiences throughout adolescence and their parents' values that were instilled. That mixture becomes the code of ethics by the time they're done with adolescence. Under lifespan development, early adults, that has to do with 19 to about 40 years old. So in this age group of 19 to 40, as you move towards 40, you'll start to see little changes throughout as far as physical. It may be harder to lose weight than you were at your physical peak, which is around 19 to 25, right? So physical peak around 19 to 25, habits, again, tend to become established around 19 to 25. Is that a blanket rule? No, it's not. But it tends to, around 19 to 25, you kind of get in a groove, right? Now, family, success, career, goal setting, it kind of starts in this period of 19 to 40 years old, right? As you progress through, you have more and more of this going on. Obviously, everyone's different, but this is a generalized approach. Now, the middle adult, 41 to 60, the aging process begins to take its toll. This can be curbed if we have a good routine, good diet, exercise, stress reduction outside of work. Now, some pearls here. Cancer is one of the leading causes of death of this age group. So I want to share this with you. Cancer, heart disease, diabetes, high blood pressure risk, family history, poor lifestyle habits will start to take toll on your aging process, on you, if you are not in control of some of these. Now, some things are in this middle age group, we can't help, but it happens. Like some cancers just occur. But other things that involve our lifestyle, we want to tackle this early. So that's the big key with middle adults. Now, wrapping up lifespan development is the older adult. This is where you're going to see more prescription medications. This is the point where the aging process, we can do as much as we can. But even still with some people, you may just have high cholesterol. You may just have high blood pressure. Just a variant of aging. You may have this heart issue, even if you're doing everything right. There could be family history issues. Now, there are different ends of the spectrum on this. But this is, again, a generalization, okay? Now, life expectancy in the United States is right around 76, 78, depending on male or female. Females tend to live a little longer. Now, 61 plus is considered older adult. Now, one of the key terms I want to go over with you here is atherosclerosis, which we talk about in the A&P section of this course. What this is buildup of calcium and cholesterol in the inner wall of your blood vessels. This causes plaque to build up in your vessels. This is where we have clots in our body, like strokes and heart attacks, right? So this is a variant of age. And it can also be a variant of, we talk about with middle adults, of lifestyle or family history. An infant is described as the first year of life. You may have heard about a neonatal period, a newborn, a neonates. It's the first 30 days after birth, so our first 30 days of life. Now, I've broken down here what you should expect. 0 to 2 months, what you should expect out of a newborn infant. up to 16 hours of sleep. That's common. Sleep a lot. In between that, something's bothering them, they're going to cry. And then you have obviously feeding periods in between sleep. It's really just a lot of sleep. Now, the biggest thing to remember with 0 to 2 months is they are not good at thermoregulating their bodies. So you'll see the baby, if you will, bundled. So obviously to expose the patient, you have to unbundle the patient. So that's something you'll see. Keep the patient warm as they have poor thermoregulation. We talked about it. 2 to 6 months. At 2 to 6 months, they're more active. They start making eye contact. They also start to recognize their parents and their caregivers, their parents versus maybe other caregivers that may be involved, right? And also, this is the big key. At the 2 to 6 month stage, if they have persistent crying or they are totally unconsolable, that's something you want to look at and say, okay, this could be an emergency or something is going on with them. Why are they not consolable, right? So that's 2 to 6 months. 6 to 12 months. Commonly, this is the babble talk stage. They're trying to get words out. They may have their first word, right? There are choking risk here. Separation anxiety is here from their parent or caregiver. Why? Here's the thing. Choking risk because they start putting objects to understand the world around them, start placing them in their mouth. So that's what we want to look at 6 to 12 months. Now, what's the big key with this infant, newborn, neonate age group? What's the big key? You want to have the parents nearby if possible. It's not always possible, but if it is possible, you can examine the child, let's say on the mother's lap, right? On scene, right? And that is an assessment you can do on scene to calm the child down and do your assessment, right? So if you keep the parents close, that's the big key because remember the big key here, separation anxiety. There. So here's our toddler. So a toddler is described, we can see here from 12 months to say 24 months. That's a good range, a good key. But basically the toddler zone is, or we could say also 12 months to about age 3. That's pretty fair. So I've broken up 12 to 18 months, 18 to 24 months just to give you kind of an idea and a key. So begin to walk, explore the environments, injury and choking risk. So when we're talking about 12 to 18 months, injury risk because now they start to actually move about the environment, and choking risk because their molars are not actually fully developed yet. So those are the big two keys. Again, we're learning more words, 4 to 6 words, maybe beginning to walk. 18 to 24 months, now we're up to about 10 to 15 words. By the time you're a 2 or 3-year-old, we hope you're up to about 100 or so words. You're naming objects. This is normal. Balance and gait start to increase. Now, what's a few keys here? So, you still have separation anxiety from your parents or caregivers still, even at age 2 or 3. You may have heard about children having a special stuffed animal or a blanket or a toy they always bring with them. If you can bring that toy into the ambulance with you, bring it with them. It helps them stay calm, right? Again, they still want their parents close by. That's still a thing. We're still looking at that. Now, the 2 keys I wrote down here, I just want to make sure you can read them. Bring special toy or blanket in the ambulance. And then you can also, if the patient is stable enough, let's say they had a stuffed, here's Tacky over. You can't see him. He's off camera. Let's say that their special toy was a stuffed tiger, right? Let's say that was their special toy. What you would do is let's say we're going to do lung sounds. We could say, hey, look, here's what I'm doing on Mr. Tacky. Now, look, I'm going to do it to you. You see? So that is something that you could do as well. So it calms it down. Well, if he's doing it, well, I can do it. So that's something you can do, obviously. And when you see a very sick child, you're not going to have time to demo stuff. I'm talking about a more calm, stable child, but maybe still has an injury or an illness. We could do that. Just want to give you a few pearls. Now I want to discuss what they call preschool age child. So we think about this as a range of about 3 years old to about 6. And then we're going to move on from there. So preschool. This is the most rapid increase in language that occurs here at 3 to 6. You may think back to maybe when you were in kindergarten. What is it about? It's all about words, it's all about letters, it's all about numbers, right? So this is a big language area we're going to focus on with preschool age. Now, what about walk and run? So walk, run, throwing, catching, kicking. activity, real activity. You know, you couldn't think about sports. Sure. Sporting activities begin at this age. So they start to have full movement of their bodies, right? Now, even at this age, because kids are curious, there's still a choking risk. We still think about that as being a risk. Now, remember, they're much more active, and now they're able to actually identify pain. They're able to communicate pretty well, using simple language, but communicating very well. They understand what you're saying. Now, you never want to lie to a patient, ever, obviously, in any circumstance. But why am I saying this in this section? Because children at this age, once you lose their trust, it's gone. It's very hard to regain trust. So you never want to lie to the patients. Maybe, let's say you're going to do an IV, and obviously IVs aren't the most pleasant experience. You got to tell them and explain that. Hey, look, here's what I'm going to do. It's got to be done. And here's what we're going to do. Be calm and reassuring, but it needs to be done. Be calm, but direct on assessments. Use simple instruction direction. These preschool age children are very imaginative. So they'll take things very literally, right? So that's a big key. Now, if I didn't talk about this earlier, I'll talk about it now. If, again, we're talking about a patient who's more stable, where we're able to do a secondary assessment, right? So do you want to do a secondary assessment on these children when you can, from feet to head? It makes it more comfortable for them, right? Obviously, in an emergency situation, we don't have time for that. But I'm talking about in more stable, right? So, if feet to head, they made a question saying, feet to head. Yes, in this age group, that makes sense. Now, the other thing is, you need to put yourself in their perspective. These are very small children, 3 to 6 years old. So you basically, to them, picture if you were as short as them, and you basically are walking up with this scope around your neck and this uniform, and they don't know who you are, and you have all this equipment with you, and you're walking up to them, and you're moving quick, right? Like, you got to get down to their level. You're basically a giant. They're a giant to them, So you want to get down to their level. That's the big key. Get down to their level. And if you remember this, down to their level, calm, but direct, you'll be good. So now we're moving on to school-age children. So school-age children is defined about 6 to about 12 years old, right? So we're right on the cusp of puberty beginning at the end of this stage. That's more into adolescence. But let's talk here about school-age children. So 6 to 12. Now, they begin, and I have quotations, begin to act more like adults, meaning the questioning, the understanding emotional versus physical pain, that becomes to take shape. They're more concrete in the way they may talk and act, more literal with things. So that's the key. They, again, begin to act more like adults in this stage. We can really see a big difference from where we came from to now. Now, they will respond directly and communicate effectively at this stage. This is the big key. Someone who's maybe under 6, we're relying a little more on getting maybe histories and getting information more from the parents. 6 to 12, especially later on, like, 10, 11, 12, and so forth, we start to kind of move towards this child's our patient. Yes, the parent is going to be assisting and should still be there. I agree with that. But we're able to do, if the parent wasn't there, it's not as much of a freak out, where the child can understand what happened to them, where their pain is, what's wrong, right, who they are, right, their history. They have a better understanding as they get farther along in this stage. Pretty cool? Okay. Now, we talked about earlier where with the toddler category, preschool age children, we might want to consider doing feet to head assessment to make it more comfortable, whereby 6 to 12 years old, we can do a more traditional head to toe assessment because they're a little older. They're a little more understanding of that. Okay. Now, one pearl I'll throw in here is that around 6 to 12 years old, the child will start to actually help take care of themselves. You notice the separation we have here? It's like we're bridging the gap from being really young to entering adolescence. That's school age. So here it is. Adolescents are 12 to 18 years old. We want to give them options where and if possible, meaning options in their care when they're stable. Now, morals will start to develop, meaning right or wrong, and also puberty will begin. Now, they also become more concerned about their appearance because they're going through puberty, and they're also, we talk about risk-taking behavior. You may have heard about adolescents saying they're indestructible. That's true, right? Now, they are physically close to adults, but emotionally, they're still children, and the last key in adolescence, vital signs are basically the same as adults, especially as they start moving towards 12, 13, 14, 15, 16, 17, 18, and above. So, vital signs here are pretty easy to remember because they're the same as adult. There it is. Before we go any farther, I want to talk to you about the respiratory differences between an adult patient and some pediatric patients. So, these could be test questions, so I'm bringing them up to you. Now, here it is. Here are the keys. First, their airway is smaller and shorter in length of the airway, the entire airway. Lungs are smaller. Okay? Think about it. That's why we have a pediatric BVM versus a adult BVM, right? The heart also sits higher up in the chest. Now, I didn't write it down here, but I want to talk about the neck. The neck will actually grow more proportional as you age. Children, it's almost like they don't really have much of a neck. And then as you get older, the neck becomes more proportional. What does this cause? Well, a few things. Let's talk about it. The glottic opening, the glottis, right? The vocal cord opening, whatever you want to call it. The glottic opening is more anterior. So at the paramedic level, if we're intubating a patient and looking in their airway, we can see that the glottis is more anterior, meaning pediatric patients could be more of a difficult airway. Okay. What else? Proportionally to the rest of their features, they have a larger tongue and a larger head. So with airway positioning, we have to pad and position that head correctly to make sure we have the patient in a good position, right? Pediatric airway, the upper airway is more wide. The upper airway is more wide and narrows the upper airway versus in adults, it's more about the same. It's more just wide throughout. And remember this key. Infants are nose breathers unless they're crying. Okay? So infants, what's an infant? First year of life, they're primarily nose breathers. Here are normal respiratory rates for each age group we talked about. So infant, 30 to 60. Toddler, 24 to 40. Preschool age, 22 to 34. School aged, 18 to 30. Adolescents, I put 12 to 20. Now, just so you're aware, most adults and most adolescents, we can all agree 12 to 20 is a good respiratory rate. But in practice, I just want to share with you, 12 to 16, 12 to 18 is a normal respiratory rate that you're going to see out in the field when someone's fine, there's no problems going on. Try to breathe at 20 breaths a minute. It's a lot. So most people end up being around 12 to 18, same with adolescent group. These numbers are based upon the systolic blood pressure of the patient. We look at these younger pediatrics on the systolic. So this is all the systolic to give you a general rule of the blood pressure. Now, a neonate, so it's 1 to 4 days. We're looking at a 60 to 76 as their systolic, their top number of their blood pressure. The neonate, 4 days to 1 month, 67 to 84. Infant, 1 to 3 months, 73 to 94. Infant, 3 to 6 months, 78 to 103. Infant, 6 months to 1 year, it's going to be 82 to 105. Child, 1 to 2 years, 85 to 104. Child, 2 to 7 years, 88 to 106 systolic. Child, 7 to 15 years, 96 to 115 systolic. Adolescent, 15 to 18, 110 to 131, basically an adult. How healthy are you? And here is our systolic blood pressures. I just want to remind you of your pediatric pulse rates. So a newborn to 3 months is about 85 to 205 in that range, right? So the big key here you're looking at is, okay, as low as 85, but if we see 160 or 170 in a newborn 3 months, we don't freak out. That's the key I'm trying to show you here. 3 months to 2 years, same thing, about 100 to 190. Again, we're not going to freak out. If we're in that range, okay, that's fine and we're comfortable. Of course, in the middle of these ranges, like 85 to 205 and 100 to 190, we're probably going to be sitting, but we're not going to freak out. We'll be okay. Now, 2 to 10 years, 60 to 140. Okay, same thing. We're in the middle of that range, fine. But if we're in the range, okay, we're okay. Now what about 10 years plus, 60 to 100? That's what we're looking at. Now with these higher scale ranges, I'd like to be in the middle, but don't freak out if it's a little high, you're still okay. The biggest point with pediatrics is please remember your pediatric assessment triangle. If you remember this, you cannot go wrong. There's 3 parts to it, and we're going to break these down even more. So, first, there's 3 sides of the triangle, 3 parts. Appearance. Appearance. I'm going to give you 2 amazing mnemonics to remember with appearance. Appearance is when you walk in the room. We see the child. What do we first see? What's our first instinct based on the feedback when we appear and see the patient for the first time? Work of breathing. We got to evaluate, and please remember this with pediatrics, the biggest thing, whether it's on test day or a real life patient, pediatrics get in trouble with their breathing. They're going to show their problems with their breathing. So this is why work of breathing is on here. Then finally is circulation to the skin, which I'm going to show you how to evaluate all this. So the first part of our triangle is appearance. Now with appearance, I have 2 mnemonics for you that we're going to cover. The AVPU and then the tickles mnemonic. If you remember these, the first part of our triangle is done. So here we go. AVPU mnemonic. This is talking about the patient's level of responsiveness. Is your patient alert, unresponsive, somewhere in the middle? That's AVPU. So A means your patient is alert to your presence. You can see they're tracking your every movement, for example. That's alertness, right? They're awake. They're able to, they're crying or speaking and they're fully awake, right? We haven't done anything and you can see they're awake. Let's say you walk in the room and they're unresponsive to you. They don't respond to you or you walk in the room. Well, then we try verbal. By saying their name, right? Or maybe our voice next to them makes them move or makes them open their eyes. That's a verbal stimulus response. They're not fully awake and alert, but there was a movement or there was an awakening from our voice. A painful stimuli means let's say we say the child's name, they're not responsive. But when we do a painful stimulus, may it be a sternal rub, may it be on their finger, let's say chicken cap refill, that's a painful stimulus, right? Even just doing that. They then respond. They move or open their eyes. That's responding to a painful stimulus. Unresponsive means none of this has worked and they're unresponsive, right? So obviously we want to be here and then it gets worse and worse and worse. Now tickles is a mnemonic that we're talking about the patient and how the patient is presenting right now. So let's go through a few things. These are the keys of assessing a pediatric patient in one mnemonic. Really cool. What do I mean by tone? So T is for tone. Tone means, is the patient vigorous? Is the patient moving about? Is the patient have good muscle tone or is the patient limp, flaccid? That's what we're looking for, right? In tone of the patient. Interactiveness is the actual patient activity and movement. How interactive is the patient with the world around them, right? That's the big key, right? Now, this is a question you can ask parents under I, interactiveness. Let's just say the child's name was Sarah. Hey, is Sarah acting appropriate today to you or is something different? That's interactiveness, right? And then how interactive is the patient with you and or parents, caregivers? Here's a big one, consolability. We talked about this in the first part of pediatrics was if we have a younger pediatric patient who is crying uncontrollably and they're not able to be consoled even by mother or father or caregiver, something's up. So consolability, are they able to be consoled either by EMS or parent or caregiver? Yes or no? Look and gaze. This is a big one. Hear me on this, folks. A pediatric patient should be very curious and watching your movements like a hawk when you're in the room. If that patient doesn't really care that you're there because they're so out of it, right? Maybe they're poorly responsive or they're so flaccid and weak, they don't even care who's there. They're very curious. That is completely not good. That is bad. So we see that their look or gaze is kind of like, I don't really care who's here. That's a warning sign. Speech. So now speech, now I also could put speech /cry, But we're talking about, when we talk about cry, is it a strong cry or is it a weak cry? Are they able to speak? Are they speaking in full sentences or not? And also speech, again, is it more weak or are they more loud? That's speech. Here are our two mnemonics for appearance. This is a big one here. We're talking about increased work of breathing. So it's our second piece of our triangle. Now I want to show you what respiratory distress looks like. If you haven't seen it, I have a great video on distress versus failure. Definitely watch that video. It is under the airway, respiration, and ventilation section, so make sure to watch that. Now, with increased work of breathing, aka respiratory distress, this is what we might see in the pediatric patient. So let's go over that. First, we have abnormal sounds. So, if we hear wheezing, if we hear stridor, if we hear grunting, right? We want to think this is an abnormal sound. This could be respiratory distress, right? So there's a few examples. Accessory muscle use. Accessory muscle use is a very common finding above supraclavicular. So above the clavicles in your patient, almost really in the neck area, right? So we see muscles pulling in from there. If we see those muscles being used, those are not normally used in breathing. Because your patient is having such a hard time breathing, now they're being recruited. Now you may have heard about retractions. So retractions, what that is, it's a drawing in. It's a drawing in of the muscles, either between the ribs as intercostal retractions, or the muscles substernally, or we're called substernal retractions, or right on top of the sternum. So that drawing in, that's retractions. That's an ominous sign of distress. Head bobbing is positioning the head in a better way to breathe. So if I'm going to breathe in really well, I'm going to bring my head back. I can breathe in really well here, and now I'm going to breathe out. Go forward. Right? That's head bobbing. So if I got to breathe in better, I'm going to go back, and then I'm going to breathe out better, I'm going to go forward. Nasal flaring is just a widening of the nares when we're breathing in. Increased respiratory rate. And then the tripod position in older children. Tremor tripod is hands out like this. So I get the best position to breathe, right? Because I'm having a hard time breathing. So this is what we look at for work of breathing. Now, respiratory failure, I want to make a quick point here while we're talking about it in children. If you hear sluggish, slow respirations or tired respirations, a slowing of the respiratory rate, right? Cyanosis, mottled skin or discoloration of the skin. These are your signs and symptoms of respiratory failure, or we have to actually go and manage their airway, right? So these are just some key terms I want to just jump in and remind you about with children. We have to know these respiratory sounds if we're going to be a competent provider, if we're good at passing our EMT, if we're good to be good out in the field. Here we go. Crackles is another name for rails. Rails is another name for crackles. It's the same thing. So if we hear rails and or goes by the same name as crackles on lung sounds for a pediatric, this means the lungs we have wet lungs. What this means, we either have pulmonary edema, which is fluid in the lungs, or we have an onset of inflammation, infection in the lungs, like a pneumonia. So we think, is this cardiac related or pneumonia? Now, most likely it's pneumonia, but we don't have tunnel vision, so it could be cardiac. Okay, never know. Stridor. Stridor is a high-pitched sound. I can hear it across the room. Stridor means we have a partially obstructed upper airway. So, could this be croup? Could this be epiglottitis? Right? What else could this be? Could this be a foreign body airway that's partially obstructed? Yes. Now, what about wheezing? Wheezing can be high or low-pitched. We hear on a lung exam when we're doing breath sounds. Now, asthma, bronchiolitis, also within anaphylaxis, those are going to be wheezing. Now, grunting. Grunting is like a sound that we hear at the end of our exhalation. At the end of exhalation, sound at the end. Now, what is that? What that is the actual alveoli of the patient. The patient is trying to keep its alveoli open a little bit longer. Remember, the alveoli is where gas exchange occurs, where we bring in the oxygen, right? So that means we have poor oxygenation. If we hear grunting, it's a sign of poor oxygenation, okay? It's interesting way that the body does that, but that's grunting. Now, absent. If I listen to lung sounds and both sides of the patient's chest are absent, no lung sounds, three things we look at. We have a full airway blockage up here because there's no air movement, or we have a severe anaphylaxis or severe asthmatic where the wheezing is so severe we're like this with our bronchi, right? Now, what if I hear on one side of the chest is absent, but this side's okay, but one side or the other is absent, right? It's unilateral, one-sided absence. Then we think of pneumothorax, like a tension pneumothorax. Think about this in trauma, and it is possible to have a pneumothorax for medical reasons spontaneously. Not impossible, but most likely this is going to be trauma. Circulation of the skin is a quick one. Now, we already brought up a little earlier about with respiratory, with the skin condition, cyanosis, mottling, discoloration of the skin. That's an ominous sign. We covered that already. But so what's the first look that we can do with circulation? Well, here I'm going to give it to you. This is something I have here. Pulse bleeding shock. Pulse bleeding shock. So here's what we do. We're assessing circulation of the skin. Give me a pulse. Do we have a pulse or not? Then we're going to go into bleeding. Expose the patient. Any major bleeding. Then, do we have any signs of shock in the patient? So if these all check out, great. Now I can go a little further. Well, now I have a pulse. Well, what's the actual heart rate or pulse rate of the patient, right? What's the cap refill time in the patient? And now give me my skin condition. Are we diaphoretic? Is the skin dry? Is it cool? Is it cold? Is it warm? Is it hot? Right? Now remember, tachycardia, the heart rate being too high, that is a sinister sign. Well, what else can tachycardia be from? Pain, anxiety, fever, right? So take that in consideration with the whole patient presentation. How do we put it all together? Well, I have a mnemonic for you to put everything that we learned together. Some of the main concepts if you get in a pinch. So here's what we have. B for blood pressure. What do we get back into blood pressure? L, what's our level of consciousness? S, skin color, temperature, and moisture. Basically, what's our skin condition? C, what's our cap refill time, good or bad? Pulse, rate, rhythm, and strength. And then respirations. What's the rate? What's the effort? What's the pattern? So the mnemonic is BLS CPR. BLS CPR puts the whole triangle together. I want to remind you of some of the common respiratory emergencies you'll see with pediatrics. Now, bring it all together. Make sure to go through the entire airway, respiration, and ventilation section, and make sure you go over all of your medications to understand how we treat all this. Now, with asthma, this is smaller airways, the bronchioles, that are inflamed, that are swollen, and excessive mucus. Here are the big triggers. Infection, so a respiratory infection, exercise-related asthma, cold exposure, smoke exposure, and emotional stress will cause asthma. Asthma is more rare in children under 1. It's more common as they get older. We're going to talk about a condition in younger called bronchiolitis in a little bit. Pneumonia is simply a general term for infection in the lungs, and it's harder to oxygenate your alveoli when there's infection and pus or fluid sitting in your alveoli, and that's pneumonia. So pneumonia, you may hear rales, wheezing, or grunting. Remember, grunting is trying to keep the alveoli open. So now, these are two upper airway emergencies. Croup versus epiglottitis. So remember, croup is a viral infection. Epiglottitis is a bacterial infection. Those are some of the key points. Another point you want to look at is croup is going to have a little bit of a lower fever, where epiglottitis is going to have a much higher fever. The other thing you want to look at is the age range. Epiglottitis can happen to anyone, even adults, where croup is really only common between 6 months and 4 years. Another thing you can look at is croup is the one with the barking cough. Epiglottitis will have stridor. They'll both have stridor, but that barking cough is croup. Croup is more gradual. Epiglottitis is a quicker onset. So let's read this through. Croup, infection of the upper airway. It's a viral infection found just beneath the vocal cords. Okay. Now, this is typically seen from 6 months to 4 years old. It begins with a cold, a cough, a little bit of a fever. Then 2 or 3 days later, boom, stridor, barking cough. Now, the treatment on croup, just like epiglottitis, keep your patient calm, position of comfort, transport, let the facility know, hey, they got someone coming in, we think they have croup, they're having these symptoms. Great. Humidified O2 is going to be the answer here for croup, right? Epiglottitis is going to be keeping your patient calm. That's going to be the biggest goal here. Could you try other things? You could, but it's a risk because the biggest thing with epiglottitis is we want to keep them calm so they're not stressed so the epiglottis doesn't swell up and we have a full airway obstruction. So it's the best thing to do actually, keep the patient as calm as possible. That's going to be the best case, especially when we're talking about BLS care for EMTs. So epiglottitis, infection of the soft tissue just above the glottis, vocal cords, right? So when I say glottis or glottic opening, that's the opening between the vocal cords, right? Now, here's our epiglottis that is being swollen, it's being inflamed, right? This is bacterial. The big thing here is a risk of a full airway obstruction. If your epiglottis, that soft tissue, is right above the vocal cords, if that epiglottis swells up entirely, then our vocal cords and our glottic opening is completely obstructed, which means we can't breathe. So epiglottitis wakes you up in the middle of the night. It is a rapid onset. Sore throat, stridor, drooling, higher fever, that's epiglottitis. So these are these two upper airway emergencies. And then we have bronchiolitis and pertussis, two more diseases I want to go over quickly. So bronchiolitis is a viral illness of newborns and toddlers. It's caused by the virus RSV, which is highly contagious. Now, this is inflammation of the bronchioles, bronchiolitis. Dehydration symptoms are a common occurrence as well. So look out for a sign of dehydration, difficulty breathing in this patient. Again, humidified O2 could work here as well. Keep your patient calm. Now, pertussis, also known as whooping cough. Pertussis is not as common in certain countries, in most countries, due to vaccination. But pertussis whooping cough, what it is, starts off as common cold symptoms, runny nose, for example. And then they get this, what they call cough attacks. So very, very, very severe cough. And with that is a whoop sound in the cough. So when they actually breathe in, that is a big whooping sound with the cough. It's called whooping cough. So you may hear about these. I just want to bring them up quickly for you. Another disease that you may have heard, an infection called meningitis. So the big key here is meningitis is very, very contagious. There are some forms that can even be deadly forms of meningitis. There are many different types. So you always think worst case scenario. So if you have a patient with meningitis, you want to place a surgical mask on the patient and you want to put N95 on yourself. Now, here's what we have meningitis. Inflammation of the meninges, the meningeal layer of the brain spinal cord. That's what's inflamed and infected. So again, covers spinal cord and brain. Fever, altered mental status, they're confused possibly. Malaise, tired, fatigue, headache, then neck stiffness because you've inflamed, obviously, spinal cord and brain. Now, I wrote a key here. Children that are either have cancer or they're already immunocompromised via another infection, or they're just an immunocompromised child, they're at great risk of meningitis, which is why we want to place that surgical mask on the meningitis patient so we don't infect others when we're going around. These are signs that our patient may be dehydrated as a pediatric. Pulse increase, slowed activity or interactiveness, urine output has decreased, cool or clammy skin, dry mucous membranes like having a dry mouth, no tears in the eyes, no tear production in young children, sunken fontanelles, altered mental status, and in the worst case would be low blood pressure. So these are some warning signs of dehydration you need to know. So I want to talk about something called febrile seizures. Febrile seizures occur commonly in between 6 months to about 6 years old. Now, the reason why I'm bringing this up, which is so important, is because febrile seizures usually occur because of an elevated fever, and they usually also occur very early on when the first 1 or 2 days of an infection. So it can be a warning sign that something is wrong with your child. So with this febrile seizure, it's caused by elevated fever, and the patient will have a short duration seizure activity, like tonic-clonic seizure activity, right? They have a seizure. The difference is, unlike an epileptic seizure, they wake up And there's no postictal phase. There's almost no altered mental status after the seizure. They just wake up out of it. And then when you get there, usually by the time EMS arrives, minutes later, because these are very short seizures, typically we call them under 15 minutes, but in my personal experience, they're even shorter than that. They're only a few minutes long, if that even. By the time you get there, they're awake and alert, and the patient's awake and alert. So I wanted to bring this up because you will see this throughout your career, and you should let the family know that this is probably a sign of elevated fever, and they should get checked out for infection in hospital. SIDS is sudden infant death syndrome. This is when an infant child has passed away, and there's no other explanation for it besides this diagnosis of SIDS. Now, there are some potential risk factors with SIDS, but there's not much you can do to plan to not have a SIDS event in the child. It is just something that happens. So I just give you the information on it. Some risk factors include young mothers under 20 years, smokers, the mother was smoked throughout the pregnancy, alcoholism throughout the pregnancy, and the actual patient, infant themselves, with a low birth weight. So SIDS is something that you may see if you go to a pediatric cardiac arrest, and you just want to be aware of this. So let's first get a baseline about geriatric emergencies and who we're talking about. An older adult is categorized as 65 years or older. Geriatric is 65 years or older. Now, what you may have seen in your own life, but also you're going to see in EMS, is that geriatric patients commonly will be on some sort of prescription medication. Remember, we're not talking about outliers. We're talking about the average person you're going to see in your ambulance who's calling you. The odds are they're going to be on some sort of prescription medication, and most commonly, it's for some of these things that you see here that are common conditions, right? The other thing I want to mention before we get into this is if geriatric patients were suffering with something when they were younger, typically it will get worse as they get older, not better. Okay? Now, this is not a complete list. This is just common things. We have a lot to go over, so hang with me. Cancer, hypertension, high blood pressure, arthritis, all right? So obviously that is issues with, you can think about muscles, with joints, muscle pain, joint pain. When I think about arthritis, that's what I think about, right? Muscle pain, joint pain issues. Diabetes, right? Now, what's the thing about diabetes? Type 2 diabetes is common in older adults. In type 2 diabetes, basically what's happening is the body is not responding like it used to insulin, or it's not producing enough insulin in the body. That's the issue with type 2 diabetes. Now, stroke. Strokes, obviously that can be common. You can survive a stroke, or you can survive a heart attack. So you might have a patient who, oh, I had a stroke, right? Chronic bronchitis emphysema, that's another word for COPD, okay, from smoking or the work they did throughout their life. I put these both here because you'll see two different terms. Heart disease is a very basic term, but I wanted to put coronary artery disease. It's very common, right? Has to do with they had a history of plaque or heart attack, so we'll talk about that. And now also put your vision problems. The thing I didn't put on here that I will mention right off the bat also, yes, vision, cataracts, we could talk about that too. But the other thing is mental illness, dementia and delirium. We'll talk about that as we go on too. So we're talking about common conditions. These are just some of the leading causes of death in older adults. So I want to go over a few of them. So first, flu and pneumonia. Why is that? So how can a younger person have a flu and pneumonia and recover, but an older person has a flu or pneumonia and they don't recover as well, right? Here's why. The immune system, remember this is caused by an infection, right? So the immune system in older adults, they are more immunocompromised. They have a hard time fighting infections, which means they can become septic, enter septic shock, right? Easier to that pathway. This is why it's a leading cause, because they could already have complications with their immune system. That's an issue with older adults. So we have your heart disease. We already went over that. Cancer. But what about trauma and falls? Now, it's not a typo. That's a little star that I put up to falls. Here's why. Sometimes, yes, trauma and injury can cause death in an elderly person, of course. But what can happen is a fall that an elderly person has can lead them to a state where they are now immobile. So I'll give you an example. You have a patient that's walks around with a cane or a walker. Then they have a fall, they break their hip. Now they're in a wheelchair. Now when they're in that wheelchair, they're recovering from this. They're on a bunch of different medications. Now they catch an infection like pneumonia. They have two things going on at once, and they pass away. It's that cascading. So a fall can lead to a whole host of other issues and problems. And then also, if they're now, in the wheelchair, they're now unable to be as active as they once were. That can cause other problems, like up here. See where I'm going with this? Right? They're more still. Right. Now, lung problems, CHF, heart failure issues, pulmonary edema, COPD, chronic lung diseases, strokes, dementia and Alzheimer's, and diabetes, right? Well, now here's the sad part, I will say, is that some older adults are going to have a multitude of these going on at once in their history, which makes them very prone to infections. Pneumonia is one of the leading causes of death by infection of an older adult. Now, pneumonia is inflammation of the lungs caused by infection, an increased risk of infection with advanced age. We talked about that, okay? Now, what is pneumonia itself? Well, it's inflammation, increase in mucus, increase of secretions. So what we have, the lungs themselves are inflamed, but we also have at the alveoli level, the alveoli, which is inflamed, which is mucus, there's pulmonary secretions blocking our good gas exchange. And that's why pneumonia is so sinister and why it's a hard time for the patient to bring in oxygen, right? Now, what are the signs and symptoms? Well, fever, cough, chills, fatigue, an increase in respirations initially. If they're going to respiratory failure, obviously they'd be going down. But we're talking about, the beginning stages, they call 911, hopefully they call earlier. It increased respirations, respiratory distress signs, rhonchi and rales. So why do I say rhonchi and rales? Early onset pneumonia, you might hear, what's to say I have a right-sided pneumonia in my right lower lobe, right? Let's just say that. Early onset, you're going to hear rales on one side. As the infection, for lack of a better word, hardens or the secretions are more dried up, you'll hear more of a roncorous, harsh sound in the lungs, right? That can give you an idea of how long the pneumonia is there as well. Now, next we have pulmonary embolism and we have deep vein thrombosis. Now, what this means, in simple terms, pulmonary embolism is a lung attack. So a heart attack is when we have our coronary artery that supplies blood to our heart and it's blocked. If I say a brain attack, a stroke, is when we have a cerebral artery that's blocked. A pulmonary embolism is when a pulmonary artery is blocked. See? There it is. Okay. Now, deep vein thrombosis. This is when you have a deep vein in your leg that has a blockage, a clot in your leg, right? Now, it's common in the area of the calf. Now, I want to skip to this. I'll go to risk factors in a moment. And you'll see other videos on PE in this course as well. But I want to bring up in geriatrics. Remember, we talk about common conditions with geriatrics, that they're going to have blood circulation issues. They may have heart failure issues. So their circulation in their body is not as good. What this means, if we have a patient with chest pain or shortness of breath, we should do a leg exam and a lung exam to check for any signs of pulmonary embolism and signs of a DVT. Now, signs of a DVT would be basically a unilateral swollen leg that's very painful on exam. So now we have some risk factors here that we can look at. Bed rest, recent surgery, patients with heart disease, artery disease, hypertension, cancer, smoking, Those are risk factors of getting either a pulmonary embolism or DVT. One pro I can give you about older adults is older adults that have long travel or that are on bed rest or had a recent surgery. That's where the alarm bells should be going off that this could be one of these sinister things. Remember, we're going to have a swollen leg, painful leg. Pulmonary embolism is going to be sharp chest pain. The lung sounds are either going to be clear or diminished, but could be bilaterally. And the most important key with pulmonary embolism is we're going to have hypoxia, which is low SpO2, but they're going to have tachycardia. That's the most key sign. So going back through our list earlier, I thought of two patients that I wanted to discuss with you. First is the heart failure patient and talking about edema. So we all typically think that when we get heart failure in the ambulance, right, and we have a patient, they have bilateral rails, they're hypertensive, right, they have pulmonary edema, they're coughing up pink frothy sputum, right, they're having a hard time breathing, they got chest pain. We think of that patient and we think, wow, this happened so suddenly. Well, here's the thing about CHF patients I want to share with you. There are some warning signs. Now, this is information for the patient themselves, but I want you to know about these warning signs because it can happen to your patient in front of you, of course. So, let's say I'm diagnosed with CHF. A few days before the CHF event, right? What can happen, not always, but what can happen, what they'll notice is increased cough, more trouble sleeping at night or staying asleep or even breathing while sleeping, and also an increased edema or swelling in their legs. Those are warning signs a day or two out if you have CHF that you're having a situation where your body is fluid overload, right? That you could be entering a heart failure event. Another thing I thought about too with elderly patients I want to mention is cataracts. So cataracts, what is that? That is cloudiness of the lens of the eye or the surrounding membranes of the eye itself. Basically, think about cataracts, they cloud your vision. They cloud your sight. The other thing, just in general, about elderly patients, is their night vision typically decreases. You may have heard of an elderly patient go, oh, I don't drive at night anymore because they can't see as well. Also, the eye will become more dry. They might have eye drops because their tear production is not there as well. They have dry eyes that can bother them or become itchy. So this is what we're looking at as far as vision as well. Obviously, it goes without saying that there can be taste and hearing difficulties as well. You'll see hearing aids, sometimes tasting foods, sometimes swallowing problems as people get older, but that kind of goes without saying here. One of my mentors taught me this, and now I want to pass this off to you. So shout out to John Belinsky Jr. for this mnemonic. What I've done is I've made a little twist to it for EMS. So I'm going to walk you through it. So it's something called the syncope grid. A way that we can actually say, hey, the patient has a near syncope or they had a syncope, which means they passed out. What do we do, right? Why is that a geriatrics? Because they commonly pass out. So that's why we're going to talk about it, right? So here we go. So this VS stands for vital signs. This is the symptom they may be having. This is do they have any signs of what we're talking about? And then make sure we do these data points. So like the reason the syncope grid was created was because newer providers have a hard time. There's so many things to look at. Someone passes out, you're thinking of so many different things. Hopefully this syncope grid gives you a good start point when you're new to say, okay, I checked that, I checked that, I checked that. So let me give it to you. So first, get your vital signs. Do they have a low heart rate? Do they have a low SpO2? Or are they hypotensive? That can point you in the direction of why they might have passed out. Next, we go to symptoms. Are they complaining of chest pain? Are they complaining of shortness of breath? Are they complaining of dizziness, right? When they wake up, right, after passing out, right? Were they complaining of this beforehand? They passed out, right? Signs. Do they have any signs of a MI, a myocardial infarction, right? Nausea, vomiting, back pain, chest pain, left arm pain, up into the jaw, right? MI. Do they have a history of MI as well? Do they have a history of CHF? Do I hear rails in the bases? Do they have pink frothy sputum coming up, right? Are they hypertensive, right? Any CHF signs that we hear? right? Do they have edema in their legs, right? Then over here on for sign, I actually put, are there any signs that this could be an environmental issue, like they just are simply dehydrated? Is it a hot environment, for example? So I put environmental and then any signs of dehydration that you might see on the patient. Data. Well, obviously, make sure to do an EKG. Get an SpO2. I would consider end titles as well on this patient because they did pass out. And the last thing we can check here is orthostatic changes. So we can have the patient move, whether they're standing or sitting, or we find them to standing up, from sitting to laying down, and see if there's any blood pressure changes that might clue us into this as being a volume issue, right? Now, we can't forget one thing. Get a blood sugar. So we gotta get a blood sugar, okay? So I threw that one in there at the end. So this is a good little syncope grid. You go to a syncope for someone who's older. What do? Here it is. Now, this can be used, by the way, for any patient of any age who passes out. But syncope is a big part of geriatric emergencies, so hope you enjoyed it. Now, here are 3 more things we want to look at with geriatric patients. Osteoporosis is a decrease in bone mass, decreases in bone strength, and an increase in the ability to fracture. Essentially, what we're saying here is the patient's bones become more weak, which is why when elderly patients fall, they usually have a fracture. Osteoarthritis, remember arthritis, the joints, progressive disease so it gets worse over time, destroys cartilage, promotes bone spurs, and stiff, painful joints. Next, I want to talk about pressure ulcers, the cubitus ulcers. So what this is here is when a patient, let's say they're in a skilled nursing facility or in hospital, or they're put on bed rest, if you're in the same position and haven't moved for a long amount of time, what can happen is you don't get enough circulation to that area of skin. In this case, the patient's been in the same position and the skin, there's no blood flow going to that skin. So there's 4 stages of pressure ulcers. Stage 1 is just redness to the epidermis. Stage 2 is actual damage underneath the skin, so epidermis to dermis level. Stage 3 invades the fat layer. And then stage 4 actually invades the muscle and bone. Okay? Now, how do we combat this? Well, you'll see constantly skilled nursing facilities rolling the patient, moving the patient, checking for ulcers. Like, this is done in like rehab facilities, hospitals, skilled nurse facilities, after surgeries, stuff like that. So we want to make sure when we're transporting the patient that they're in a position of comfort and that we pad all the voids to make sure they're most comfortable and we can avoid pressure ulcers. Another quick note here on polypharmacy. Now, in this course, you're going to see a section called Prescription Meds Mastery. That goes over all of your most common prescription medications. So make sure to watch that. Now, we're talking polypharmacy. Again, older adult patients, over 65 years old, they're commonly taking more than one prescription medication. When you work EMS long enough, on a daily basis, you will see patients, and I'm not kidding, that have over 10, 15, I've seen even 20 or more medications that they're on. Or we're talking about patients that are at a skilled nursing facility or end of life, right? So mistakes happen. EMS can be called because there's either a dosing error, a medical error, or a prescription medication with an adverse effect that they didn't expect, or a cardiologist doesn't talk to, let's just say, a pulmonologist, and then they're prescribing either meds that are contraindicated to each other or don't interact well with each other. So this has all happened. So just know this can be a scenario that you witness. I did want to touch on a sad point that sometimes older adults, especially those without daily activities or recent illness or injury or loss of a loved one, could be suicidal thoughts and depression. And when they have access to all these medications, this can be a route. I did need to bring up because, again, you will see this as well in EMS. Now, you may have heard in class about the GEMS Diamond or the GEMS Diamond assessment. So you're called to a 911 call for a geriatric. What's a mnemonic I can give you to assess them in a situation? The GEMS Diamond. Here it is. G stands for, well, you're going to a geriatric patient. And I'm going to give you just a few things to remember about the geriatric patient. E is environmental assessment. We'll talk about that. Medical assessment and social assessment. The geriatric patient, things to keep in mind. Geriatrics, they kind of remind me of like diabetics, where diabetics, geriatrics, older adults, they present atypical. So you always want to be on the lookout. If you go to an elderly patient that normally walks and talks and normally takes care of themselves, and today they're so tired they can't even use the bathroom and get up, don't get lulled into their age. Oh, they're just their age. You want to ask what their baseline is, and that can clue you in. Whoa, what do you mean she runs and walks? You see where I'm going with that? So I never assume anything. What do? We always think worst case scenario on our assessment until proven otherwise. Then, the other thing we want to look out for is they present atypically. That's geriatrics. Now, the next piece here is environmental. So environmental assessments, there's a ton of questions that you can go over on their environment, but mainly, how is their environment? A few things I think about. Is there any hoarding going on? Are there area rugs where there might be a fall risk? Is the patient eating and drinking well? As far as the patient, are they living by themselves? Where are they living? Are they living with others? Is there any sort of abuse going on? See, these are things that can go off the top of my head, things you're thinking about, right? How does the fridge look? Is there food in the fridge? Are they taking their medications? Are they able to manage their own medications? This is all basically with environmental. Now, medical, you could say that medications that are medical. That's fair. But medical assessment, really what I'm talking about here is patient assessment, the physical exam, getting your normal patient assessment and history on the patient. And yes, that includes medications too. So with the social assessment, what we're looking at is their ADLs. So what that has to do with, that's their activities of daily living. So we're also looking at their social and their support network. So are friends and family close? Again, like we talk about who they're living with, but really social is their activity, and then what can they actually take care of themselves? So what this means: eating, feeding, bathing, walking around. Are they able to drive, like stuff like that? How do they operate day to day? So this is the gems of diamond. This is what we look at on a geriatric patient. So our last part here is on falls, and I've made a list here of things to think about. So we go to a fall. The first thing that I'm thinking about is, was this fall witnessed or unwitnessed? What this means. Do we have friends, family, bystanders on scene that saw the fall event happen to the patient? Or unwitnessed or unknown, we don't know exactly what happened because the patient doesn't know, or there's no one that saw the event happen. And now, let's say the patient is confused. We don't know if they were confused before or not. They're just alone, right? So that can be the unknown or unwitnessed, right? So past that, we try to figure out some of these things. Did they pass out? Did they have positive LOC, means they lost consciousness? That's LOC. What are the present symptoms and complaints? We want to treat those. Do they take any blood thinners, anticoagulant medication? Again, under Prescription Meds Mastery. You want to get better at geriatrics, go to Prescription Meds Mastery now in the course, watch all the videos at least twice. Now you're going to be a pro, okay? So, are there any blood thinners? I got a video on anticoagulants there. Was it a mechanical fall, meaning I tripped and fell, versus, oh, I got dizzy and I fell over, right? Was there, oh, I fell because I have chest pain? Oh, I fell because I got a headache? Oh, I fell because I'm so tired? Or was it, oh, I tripped and fell on the sidewalk? You're going to do your DCAT BTL assessment. Make sure to expose your patient. Make sure you do your full assessment, head to toe. Now, what height did they fall from? So did I fall from standing, sitting? Did I roll over out of a bed and fall? Did I fall off a roof? I mean, what's the height of my fall, right? And then finally, when they did fall, did I strike an object and then fall, or did I fall right on the ground? Did I brace myself? So these are all the things I'm thinking about on a fall patient. We have here developmental disability and intellectual disability. So we're talking about developmental disability. That's like at the top of the key. That's the broad term. A subset of developmental is intellectual. So let's just define our key terms here. Developmental disability group of conditions that may impair development in these areas. It could be a physical ability limitation, a learning limitation, a language limitation, or a behavioral coping skill limitation or disability. The intellectual disability has to do with where the patient has limitations. Now, we're going to talk about this in a moment, how it can vary. Has limitations with daily living and or intellectual functioning, okay? This can be very mild or profound, and the level of care varies greatly from person to person. Every individual person, when we talk about from mild to profound, we talk about the care they receive, it's usually on a person-to-person basis, meaning patient A can have Down syndrome and patient B can have Down syndrome. But the level of care and how profound the actual disability is not determined by the diagnosis, it's determined by a person to person. So there will be differences that you'll see. Final note here that I have is using family and caregivers on scene for you to get a baseline of what normal is for them and what is abnormal about them today. And they also will give you, little tips or tricks and how to best manage the patient if they are, on the more profound side of their disability. So now, of course, it's EMS. They may not be there, but if they are, you want to use them to help guide and also comfort the patient too. Autism spectrum disorder also is called ASD. It is a spectrum. So, patient A could have autism, whereby patient B can have autism, but they're completely different, right? And in terms of care or how they interact with the world around them. So what is it? Well, it's an intellectual disability with deficits in social skills, communications, and interaction with others. The hallmark sign is repetitive, restrictive patterns of behavior in certain interests and certain activities. They keep doing the same things over and over and over and over and over again, and they're avoiding other stuff. So, avoiding eye contact, repeating words, doesn't engage in play, not responsive to others. Now, some patients with autism are nonverbal. They don't talk. They can still understand you, but they don't talk. They could also have speech or verbal delays as well. Now, Down syndrome. The thing with Down syndrome is that they have an extra chromosome, an extra pair of chromosomes. Now, let me explain this. The normal human cell, there is 23 pairs of chromosomes. What happens is about 9 out of 10 times with Down syndrome, you're going to see this. Chromosome 21, instead of being a pair, of two, you have 3 copies. We have 3 copies of chromosome 21 instead of the normal 2 pair, right? So, with Down syndrome, it's a genetic chromosomal defect. Results in mild to severe intellectual disability. Now, it's key to know that some patients with Down syndrome can actually live independent lives, like work, vote, all the things you think about, like a normal independent person doing, right? People with mild Down syndrome can do a lot of those things, but also Down syndrome can be more profound. Again, there's a scale with that. So just to be clear on that. Now, we talked about the pairs. Understand that, number 21 has 3 copies instead of 2. That is Down syndrome. Now, what are some of the things to look out for? So here it is. There's some physical abnormalities, especially with facial features that you'll see in somebody with Down syndrome. They also tend to be a little bit on the smaller side as well, someone who has Down syndrome. The other thing you're going to look at is thyroid problems, hearing and vision. And I'm also going to add heart problems, which goes into my next piece here on increased risk for medical complications. So as people with Down syndrome get older, it's not a rule, but they're at an increased risk of metabolic abnormalities in their body, okay? Now, what about something that could happen? A Down syndrome patient could be at a traumatic event. They could have an airway issue, right? This is all possible. they're going to likely be a more difficult airway because they have a large tongue and a small oral and nasal airway. So typically, Down syndrome, this would be a difficult airway case. So now we have cerebral palsy. Cerebral palsy is about movement. Cerebral palsy is about poorly controlled limbs. Now, there are other factors, but that's the big key. Now, let me paint a picture for you. We can have a mild case of cerebral palsy on the milder side where the patient may have an unsteady gait, yes, balance issues, but is able to walk. On the communication side, may even have a normal IQ, right? Or slightly depressed IQ, but is able to hold a conversation, for example, right? The key here is not every patient with cerebral palsy presents the same. There is a difference from mild to severe. So now I've painted a picture. Now let's talk about this. Cerebral palsy, a disorder of poorly controlled body movements, can be caused by, why does it happen? Now, there are many reasons, but some reasons I added here is damage or trauma to the fetal brain in uterus or lack of oxygenation during birth. Okay. Now, what are some keys to look for? Poor posture, uncontrolled spasms of the limbs, visual or hearing difficulty, communication difficulty, seizure or epilepsy, seizure disorder like epilepsy, unsteady gait and balance, and use of a walker or wheelchair. So those are some key things. Now we're trying to see the difference between each disorder. Spina bifida is a birth defect that is an exposure of the spinal cord. So it is exposed to the outside world. It's not underneath the skin. So with spina bifida, what could happen is there is damage to spinal and or neurologically in the patient. This is spina bifida. So it's a birth defect. It's an incomplete closure of the spinal column. The result is an exposed section of the spinal cord that you'll be clearly seen at birth. Even if the spina bifida is corrected, if you will, by enclosing and making a closure of the spinal column, even if that's corrected, the damage to the spinal cord and the neurological damage stays. So let's just talk about this right here. Surgery can correct it, but the spinal or neurological damage will remain. Just talked about that. Now, some patients may have full or partial paralysis to their lower extremities. So you may see like an unsteady gait, stuff like that, a more of a challenge for them while walking. You may see that, for example, if it's on the partial side. Now, if we look down here, loss of bladder or bowel control can also happen in patients with spina bifida as well. The odds are there's probably someone in the community that you're going to be working EMS in. You're going to come across somebody with spina bifida. A tracheostomy is a procedure where a hole is placed on the front of the patient's neck to give us access to the patient's trachea so the patient can breathe successfully through the trachea, and then at other times can actually be ventilated via a ventilator through that trach as well. Now, with the tracheostomy, it is a surgical procedure that creates a stoma. So a stoma is another word for the opening at the trachea site through the neck, providing a pathway to the trachea so we can breathe. Great. So a tracheostomy tube is placed for ventilation. So this is the procedure. The stoma is the actual hole or opening, and the tracheostomy tube is the device that we're going to ventilate through, right? Now, a tracheostomy could be a temporary measure or a permanent measure. Now, what's the biggest key I can tell you? These tracheostomies constantly need to be cleaned because they are at a great risk of mucus plugging. So if there's someone there as a caregiver, like caregiving for the patient, they're going to be constantly cleaning that to make sure it's clean, everything is not being plugged up. Now, some patients with a tracheostomy will require ventilator support at home. So they'll have a ventilator at home and they'll be managed by a care team, or sometimes you'll even see the family as well. Now, this is a mnemonic here. This is a great mnemonic for you go to somebody, they have a tracheostomy in place. they have a tracheostomy tube in place, whether on a ventilator or not. But they're called for a respiratory emergency. They got a trach. The first thing you think about is dope. The dope mnemonic. This is what it is. The old dope mnemonic. Here it is. D, displaced, dislodged, or damaged tube. So check for that first. Is the tube displaced is not in the right spot? Dislodged? Is it damaged? Check for that first. Second is what I talked about earlier. Is the tube obstructed? Could it be secretions or vomit or blood or mucus or a foreign body? Check for that. Okay. Is there a pneumothorax going on right now? Which obviously no, anytime we're pressing air into somebody, ventilator, CPAP, whatever it may be, right? We are at risk of a pneumothorax. So pneumothorax is definitely a risk. E, equipment failure. Is a tube kinked? Is there simply just no oxygen supply going on? Is the ventilator settings wrong or malfunctioning? Is the ventilator malfunctioning? So we check all these things. Now, what's the big pearl here, folks? This tube is thought of as any normal tube that we have. So, for example, if I have a patient with an ET tube and they're intubated, of course, well, let's say I don't have a ventilator, for example, I'm going to attach the BVM and breathe the patient, right? Right. So, the same thing with this tracheostomy patient. When in doubt, let's say it's an equipment failure. Let's say for whatever reason, nothing's working, right? You can bag the patient through the tracheostomy. And now you're providing ventilations. Either on your oxygen, you're providing ventilations, you're breathing for them. That's always a place to think of. That's your fail-safe. That's your fail-safe method with tracheostomy is BVM ventilations. You can still do that, okay? So just want to share that with you as a fail-safe option. I always talk to you about, I don't want you to be off guard. And as an EMT or paramedic, you have to be adaptable. You know, you're entering someone's home who may be an expert and care for this stuff every day, and you're there first time. So I've made a list of some of the most common devices, specialized devices that some patients with special challenges are going to have, so you can understand them. The trach we talked about already. Let's talk about these. So first is an internal pacemaker. So the idea, what a pacemaker does is it regulates the patient's heart rate. That is the goal. So it's not too slow, it's not too fast. The heart obviously is weakened or ill. So in this case, the pacemaker is regulating the heart rate so we have a good conduction. That's what we're looking at, right? Normally, the pacemaker is implanted in the patient, either in the chest, or if they're very thin, it could even be implanted in the abdomen as well, but typically it's in the chest, okay? A ventricular assist device, this is called an LVAD. I have a great follow-up video that you can find on the LVAD in this course. Just search LVAD and you'll see it pop up. Now, what ventricular assist device, the whole goal of this is it's a bridge to a heart transplant. Meaning this patient has a weak, failing heart. The ventricles are not very strong. So this ventricular assist device allows the ventricles to actually contract. So we have blood flow to the rest of our body. This is a great device because without it, these patients would probably pass away. The LVAD gives them more time, which is great. And it works very effectively. I've seen many patients with LVAD and it works great. Now here's the key. They're not going to have a palpable pulse. Doesn't mean they're not, obviously blood is flowing, but they're not going to have a palpable pulse like a normal patient would. That's the key with the LVAD. Again, more on the LVAD. I got a full video. Just search LVAD and you'll find it. That would be really helpful to you if you're concerned about it. External defibrillator vest. This is on a patient would wear this vest. It's basically a monitor and the pads are attached. So this is worn by someone who's really at risk of a lethal rhythm on EKG. Next is a central venous catheter, also called a central line. So let's say I do an IV out here. This is a peripheral line, right? A central line usually placed into the vena cava in the patient, right? Quite a large vein, right. So this is patients who have frequent IV meds, could be chemotherapy, pain meds, antibiotics frequently. Someone who's frequently getting IV medications, they'll place that, so they're not always placing them all throughout their arm, right? It just sits in there and then it's much easier of use. Now, they're called G tubes. You may have heard about placing an NG tube, a OG tube, right? What this is, these gastro tubes are used in patients that are not able to feed by mouth, right? So, can be fed by mouth. It can be oral, nasal, or can actually be placed directly to the stomach for the G tube. Next is shunts. When we're talking about a shunt, the most common thing we're talking about is a patient with hydrocephalus, which is basically an accumulation of too much fluid, CSF fluid on top of the brain. It puts pressure on the brain. So the shunt is used to drain the fluid off the brain so the brain can relax and not be so under pressure and stress. Now finally, we have the ileostomy and the colostomy bag. Now what is that? So this is for patients, it's a surgical procedure that creates an opening to their either large colostomy or ileostomy, small intestine, to allow elimination of waste products. Now you will also see down here a urostomy bag. A urostomy bag is used for elimination of urinary products. So meaning that's our waste from the urinary system. So let's say someone doesn't have a bladder, for example. That would be the case for that. Now, if someone has problems with their large or small intestine, this is where we're going to use a colonostomy or an ileostomy bag. Medical terminology is the medical language. You're going to learn new words and abbreviations in medicine. That's what medical terminology is about. Now, depending on the provider that you're talking to, they will use more or less medical terminology. Obviously, when we're speaking to the patient, they want to talk in simple language, be direct, they can understand us. But when we're talking to provider, or writing stuff in our documentation, this is where a lot of medical terminology comes in. Also, think about medications, think about different diseases, different emergencies. It's all medical terminology. So we got to understand this. Describing an exam even, for example. So these are the four main parts of medical terms, the language of medicine. So the word root is the foundation of the word. Basically, what's the key term of the word? What's the main part of the word? The word root. The prefix is what occurs before the root word. The suffix is what occurs after the root word. And the combining vowel, typically it's an O. It's not always, but typically it's an O. That there's a vowel that joins two or more, it could be one or two root words, right? When we're talking about the combining vowel. So there'd be an O by the middle of two root words. Let's continue from here. So let's start with the word root. It's also called the root word. You could say word root or root word, same thing, same meaning, just so you're aware. So it usually describes a body part, organ, or organ system. So here I have some examples. So let's start with cardi, which means heart. Okay. So like bradycardia, slow heart rate, right? So brady is slow, and then cardi is starting with the heart, bradycardia. Pretty cool, right? So here we have hep. You can see here, H-E-P-A-T means liver, like hepatitis, right? Inflammation. So anything that ends in itis is infection or inflammation of what I'm talking about. So here's the liver, and it's saying it's inflamed. Boom. Okay. Neph. So basically nephro, essentially. Okay. In this case. So neph, kidney, nephropathy. Right? Nephropathy. What do we have with that? Disease of the kidney. Pretty cool. What else? Neuro. Right? So nerves, neuralgia. So neuralgia. What is that? That has to do with nerve dysfunction, disconnection, and can also be nerve pain, neuralgia, right? Psych. Talks about the mind. Psych means mind. Psychosis is a disconnection from reality. So, once we start understanding all these root words, we kind of know what's going on. All we got to do is figure out the rest of the pieces to bring it all together. Now, these are our prefixes. So with a prefix, remember, not every medical term has a prefix. So that's the big key. Not every term. A prefix gives a root word a certain meaning because the prefix is there. So I'll give you an example. So here are some common examples I have written out for you. So we'll start with hyper and hypo. So hyper means excessive or too high. Hypo is, under or too low, right? So hypertension is elevated blood pressure, where hypotension is low blood pressure. Another common term that just never would fit here would be hyperventilation and hypoventilation. You'll see those a lot. So ventilation talks about breathing. So we're either breathing to, our ventilation is too much or ventilation is too little, right? Now, next thing we're going to look at here is tachy. So this is fast and slow, okay? So we have tachy, fast, brady, slow. Like tachycardia, bradycardia, right? So we're talking about the heart. Heart is too fast, heart is too slow. Notice again, the prefix gives the root word a certain meaning. See, here's our talking about pressure, the heart. See, pretty cool? Okay, excellent. So now, there's two words over here I want to share with you. Now, we have tachypnea and bradypnea. So these two words have to do with your breathing rate. So this is your respiratory rate itself being too fast or respiratory rate being too slow. Okay, the rate itself. Okay, what's next? So we have pre and post and then A. So pre is before, post is after. So like prenatal, before birth, post-surgical, after surgery. Then A means without. So if I'm apneic, or we hear about apnea in the patient, no breathing. There's no without breath. Proper term, without breath. There's no breathing. And there it is. Now with suffixes, remember, this is at the end of our word or term. Usually it indicates a procedure, a condition, a disease, or part of speech. Now, here are some common ones here, and I give examples. Here we go. Al means pertaining to. Notice ick also is pertaining to. Apneic, right? So apneic. Remember, now we can put some of these together, right? We have a prefix here, right? We have the PNE, which is, we know talks about breathing. So basically we have here pertaining to without breathing, right? So apnea without breathing, apneic is the same, pretty much the same thing, right? We're not breathing. We understand that now just from this one lesson, right? So syncope, the word syncope means that we have basically passed out. We fainted. So a syncopal episode, it's pertaining to a syncope, right? Now what else? We talked earlier on about, I wrote here for you again, neuralgia. We've heard that word before. Oh, neuralgia. Is it a dysfunction of nerves? Yes. But now, what does it mean in this term? Well, anything with an algia is pertaining to pain. So, neuro, we're talking about the nerves, and then algia, so that's a nerve pain, folks. That's nerve pain, right? So, ectomy. What else? So, ectomy is removal surgically. So, a tonsillectomy. I remove your tonsils surgically. We talked about this one already with the apneic. Talked about that already. Itis. So, endonitis is inflammation or infection of. All right? Now, the key term is inflammation. I like to remind you that if something's inflamed, it's usually infected. So that's why I kind of plant in your mind to remember that. But the key term is actually just inflammation. So, itis, inflammation of, in this case, the myocardium is inflamed. Okay, what's that mean? Well, here we go. Myo is muscle. We learned cardi earlier is heart. So that means I'm talking about heart muscle is inflamed. Myocarditis is inflammation of the heart. Inflammation of the heart muscle. Right? Megaly, enlargement. So if I say you have hepatomegaly, what does that mean? Remember we learned earlier. See, we're bringing it all together. Now we've learned a good amount. Remember, the Remember where the HEPA? HEPA is, that's your liver. Megaly, enlargement. There it is. Oma means tumor cancer. Lymphoma is cancer of the lymphatic system. Pathy means disease. Watch this one, folks. Cardiomyopathy. That is a cardiac muscle disease. Now, our last piece is combining vowels. So with combining vowels, it's very simply just placing a vowel. Typically, it's the letter O. It could be other vowels, but typically it's the letter O and inserting that between two root words. That's most common. So I have some examples here for you. So here's cardi. We have the O, cardiology, right? Gastro, hepato, arthro, osteo, pulmonary, for example, right? So, or pulmonology, right? Could be one. Now, cardiology. Cardi is heart. I take out this O right here. The last part, the logi, is study. The O connects cardiology, heart plus study. Now, look at this one here, osteoarthritis. So, with oste, that's going to be a root word, which we have right here, oste, right? There's oste. The O, there's our combining vowel, right? Arth, which also right up here, another root word. And then we have a suffix, which is going to be itis. So we have here is bone plus joint inflammation, reading it literally. Now, if you don't know what osteoarthritis is, it's when your joint cartilage breaks down so much that it's bone on bone. A typical finding for this would be like the knee, for example. So now I'm going to throw you a curveball. Now, I'm doing this. I want to make sure that you are squared away when you see some of these oddball ones. So, there are some root words that describe a color in the human body. So, let's talk about it. So, here we go. Cyanosis. Cyanosis is blue discoloration of the skin. Now, why does that happen? That's a sign of respiratory failure. Don't forget that one. Probably the most important one. Here. Leukocytes. That means white blood cells. Erythrocytes. Red blood cells. So, this is white. This is red. This is blue, meaning they describe color. Black. Now, this is something you're going to see in gastrointestinal, okay? GI bleeds, gastrointestinal bleeding. Okay, we have here is melena. So, black, tarry stools found in GI bleeds. So, I just wanted to throw these in here to make sure you're aware of them because you will see them throughout your career. Now, these are our directional terms we got to know. So, let's break it down. So, front, it means anterior. So, anterior. The back is posterior. Okay. Top, above, superior. Below, bottom, inferior. Closest is proximal. So, distal would be farthest, right? That's what we're looking at. So, proximal, closest, farthest, distal, right? Middle, medial, lateral, side. Like a deep vein thrombosis, in, deep. A superficial burn, out, superficial, right? Ventral is just, the way I think about it is, ventral is talking about the belly side or this front side of the body. The dorsal is talking about the back side or the spinal side of the body. So here are your directional terms. I want to add just a few more terms here that I talk about a lot in this course, and you'll see around EMS. You got to know this so you're not confused. So bilateral versus unilateral, I talk about that a lot with lung sounds. So bilateral lung sounds, right, or bilateral chest rise, you're going to hear that a lot. It means, so the chest, both sides of the chest are equal, or up and down. A bilateral lung, if I say your patient has bilateral wheezing, there's wheezing on both sides of the lung, right? If I say your patient has unilateral absent lung sounds, that means this side of the chest, one-sided, has absent lung sounds. So unilateral is one side, bilateral is both sides, okay? Supine versus prone position is very common in EMS. Supine is I'm laying flat on the floor, so I'm laying on my back to the floor. If I'm laying on my stomach to the floor, that's prone, prone. You may have heard about Fowler's position or semi-Fowler's position, right? Semi-Fowler's, what that is basically just sitting your patient upright with the head of the bed up at a 45-degree angle so they can breathe better. That's why that position was created, right? Another position that you will see is a recovery position or a lateral position. Has to do with putting the patient, lateral is putting the patient on their side. Like if I say left lateral, I'm going to move to that left lateral side, right? That's what I'm talking about. Now, the recovery position is a position where we could put patients that are post-seizure and or could also be if your patient is going to, let's say they're at risk of vomiting and they're, we're not without the stretcher yet. We might move them into that position because we don't want them to, you don't want someone to throw up while they're laying like this, because it's going to throw up like this and then they're going to choke on their vomit. So we lay them on their side, which is part of the recovery position, then they come out this way. There it is. Some of the first things we talk about with medical, legal, and ethics is determining, is the patient of sound mind? So in medicine, the patient has to be of adult years and sound mind, meaning they're alert, they're oriented, they're not under any drugs or alcohol, to actually make their own healthcare decisions at that present time that you're there as EMS, right? So here's a few things that we look at. So deciding whether a patient is of sound mind and can make their own decisions. First, what's their AFPRU score? So they should be alert on this. Are they alert and oriented times 4? What that means. Are they alert? Okay, great. Are they oriented to themselves, to the time, to the place, and to the event going on right now? Yes, good. Is there GCS 15? Yes, good. Okay, so they're off to a good start. Are they at least 18 years old? Okay, we'll talk about minors in a little bit, but in this case, are they 18 years old? And then 2 more things here. Is there a language barrier? Because if there is a language barrier, what you're saying to them may not come across. So we got to figure that out and work that out. The other thing I want to look at here is, are there any drugs and alcohol on the patient side where that could cloud their judgment, right? Because sound mind means that you are sober. You're not under drugs or alcohol, right? If you're under drugs and alcohol, you can't sign, right? So, this is where we have situations with refusal, stuff like that. We'll talk about this as we go on. But these are some of the things we talk about when I say, are they adult years and sound mind? Here are your types of consent. So first, you can see here from the board, we have expressed consent. Expressed consent means the patient is telling you, I want you to take me to the hospital. I am hurt. Please help me. Take me to the hospital. That's the most literal way of saying it. Now, I'm going to read everything I have to you here because I know it's a little jammed. So express consent. I want to be transported by you to the hospital. Take care of me, please. That is I couldn't make it any more clear. That is saying that, yes, I want your help, EMS provider. Take me to the hospital, right? Informed consent has to do with us. So informed consent, what that is you telling the patient either what procedure you're about to do, what transport is like what's next. So, okay, you want to go to the hospital. Okay, here's what we got to do. We're going to get you on the stair chair. Then we're going to bring you onto the stretcher. Then we're going to get you in the back of the ambulance. Then in the back of the ambulance, we're going to do EKG, IV. We're going to give you some medications. Yeah, right. And obviously, it's not all at once, but each step in the process, you're gauging consent. Every action you do with the patient, you're going to gather consent. If they're awake and alert and they're of sound mind, we got to get consent along the way, right? So remember this, folks. A patient can refuse care, totally, but they can also refuse a procedure. But they gotta be of adult years and sound mind. If they're not, then it comes under implied consent. So implied consent means you are either, let's say you're very unstable, you're altered mental status, you're confused, you are someone who is unresponsive, right? So picture this. Somebody with a stroke or a seizure is having a bad medical event, right? They're altered, right? Let's say someone had their first seizure, they're confused, or their first stroke, they're confused. They might even be combative with you, but they're really ill, right? Right. Under implied consent, the law assumes that they would want care from us, right? What if someone's unresponsive from an opiate overdose? The law assumes that person would want our help, right? What if they're unresponsive due to a heart problem? The law assumes they want our help because they're not awake, right? That's implied consent. The law assumes that they consent because any person with a serious injury would say, yeah, I'll take the transport. It assumes that in the law. This is all by the law. Remember, medical, legal. So minor consent. Now, when you actually do your documentation in EMS and you have it could be EMS charts. There's many different systems. Different companies have maybe their own internal systems. But give me an idea. There's different options. So someone's assigned for the transport. So as far as someone assigned for the transport, there's a few different things. So we're talking about the person actually signing that, yes, I wanted to be transported. You have to be of adult years and sound mind to sign on your own transport. If you are a minor under 18, you can't sign your actual EMS chart. So what this means, you want to try to get a signature from the parent or guardian, right? So what if the minor is there alone? Do you delay care? No. So if a minor is injured, you're called there, but there's no parent or guardian or caregiver there, you treat the child, transport, and then try to, either at hospital, en route, whatever, get in contact with the parent. Or have a bystander kind of get in contact with the parent while you're providing care, right? This is common like schools, for example, right? They wouldn't be there. So minor consent, they're not going to sign for the transport, but you're not going to delay care of a minor. You're going to transport. Again, you're assuming, okay, the parent would want their child to be transported. They're sick, right? They're ill, injured. Now, what's involuntary consent? Well, involuntary consent has to do with a few different things. Let's say a prisoner needs an evaluation. That would be involuntary. They're a prisoner of law, right? The other ones here, I wrote down a mental health crisis, a mental health evaluation, emergency detention, some may call it, getting papered, some may call it. It's a little slang there. What this means, a doctor or law enforcement is saying, you, patient, involuntarily must go to hospital due to the mental health crisis you're in right now. And that's in the law, right? Now, us as EMS, we have to execute that because we're EMS, we got to transform there, right? Now, we talk about this in behavioral emergencies, so make sure to watch that video, but it's under the medical section. But this is involuntary consent. You're going to see that too. Okay, so these are all covered. Now, the only other pearl that I'm just going to throw at you real quick before I go on this section is this. We want to always try our best to get at least 2 signatures at hospital. So we want to get the patient signature or the parents in this case. So patient or parents. So if they're adult, patient. If they're the minor, get the parents. That actually signs for the transport itself. When we transfer care of the patient, we want to get a signature from the nurse or the doctor we transfer care to. That shows on a documentation that we transferred care by that signature. The other patient signatures show that they want to be transported. That's how you cover yourself in EMS. So let's talk about patient refusals. So there's a form. We're talking about, again, narratives, documentation, charting, stuff like that. Let's say you go to a 911 call, and let's say it was for abdominal pain. You get there, and the patient ultimately decides, I don't want to go to hospital, right? Let's say that's the case, right? The patient is able to do that with any ailment as long as they're of adult years, of sound mind, and they are alert and oriented. As long as they're alert and oriented of adult years, sound mind, no drugs or alcohol, they can do that. Now, here's the key. I'm going to go through a few. The patient has a right to refuse care altogether or a certain procedure. There have been, I'll give you an example, a few times throughout my career where, let's say I'm transporting a stable ALS level patient, right? Let's say we're doing EKG, but maybe give a med or something like that, and go to do an IV in the patient. Patient goes, I'd rather do the IV in the hospital. Can we wait? I have to tell them, look, here's why I want to start the IV. This is what we want to do. And they can refuse it, right? They can refuse any procedure or care altogether if they're adult years and sound mind. Make sense? Okay, cool. Now, another pearl I want to give you here. You need to tell the patient this is the super key. You need to tell the patient all the risks associated with refusing care. So, for example, if the patient has abdominal pain, you have to tell them what's the worst case scenario, what to do if the abdominal pain comes back, what to do, some tips on managing it, right? You want to give as much information as possible to the patient so they can make an informed decision, right? If they're not going to go to the hospital, then, hey, I recommend you do this. If this happens, call us back. this happens, call your doctor, so on and so forth, right? This is where you're trying to be as helpful as possible as a healthcare provider to the patient. Now, this is the documentation pearl. You should ask the patient and document that you told the patient, at least, describe to the patient that you're willing to transport him to the hospital at least 3 times. And also document all the risks that you explain to the patient, right? Up into including them dying, passing away, right? This is very important. The patient they can refuse, but they need to know the risk associated with it. And they need to know 100% that you were willing to transport them and then they said no. It needs to be documented. And then on your chart, you get a signature from the patient who's alert or oriented, adult years, sound mind, signing that they refuse care. Now everyone's covered. Patient's covered. Patient's happy. You're covered. We can go to the next call. So we're talking about end-of-life care, your terms you're going to hear about. So let's just go through them real quick. So DNR, usually it's a bracelet and a document. There's 2 terms here. So DNR, do not resuscitate order, which means the patient was to go into cardiac arrest. We would not provide BLS, ACLS, PALS, whatever support we're talking about. We're not going to provide that resuscitation support to the patient, right? DNI means do not intubate. Okay, you might see that. Advanced directive is what should be done if the patient is unable to make decisions. So an advanced directive is a form, a document, and it explains if I am incapacitated and I am unresponsive, what should be done, right? That's an advanced directive. A power of attorney is the person in charge if the patient is unable to make decisions. Now, these are signs of what we call a DOA, which is also known as dead on arrival. So these are signs that your patient has passed away. Now, these first 2 I want to start with. Let's say we have decomposition of the body. At that point, we know we're not working this as a cardiac arrest. This is going to be a DOA. Decapitation, these are 2 circumstances where life is completely incompatible. Now, here are our big signs and symptoms. An unresponsive patient, no carotid pulse, we listen to the heart, no hear a heartbeat, no chest rise and fall, no breathing, no pupil activity, fixed pupils, no activity, no change, no blood pressure. So these are our big keys to say, okay, now here are some other keys we talk about, stuff that you might hear about with end-of-life care, stuff like that. Rigor mortis, stiffness in the body muscles. Dependent lividity is blood pooling to the lowest point in the body, depending on where the patient is positioned. Algor mortis is the body's temperature cooling to match the room temperature or ambient temperature. Putrefaction is the actual decomposition of the body's tissues. And that takes about, if a patient is found in this state, then they've probably been deceased for at least 40 to 100 hours. Okay, so more key terms you're going to see. So first is scope of practice. Scope of practice means that's your boundary of EMS care. So I'll give you an example. Let's say there's a certain medication that is outside of your scope of practice. You couldn't use that medication. Or there was a certain procedure that's outside of your scope of practice, and you would not be able to do it. It's your boundary of what care you can provide. You never practice outside of your scope of practice. Never. Now, the protocols is the guide. It's literally a written and digital guide to certain and exact situations. Meaning, your patient is in SVT. First, you try this. Next, you try this. That's like protocols, right? Standing order means what you can do. You don't got to ask permission. You don't got to talk to nobody. Standing order, you can do, just you have the tools, you have the meds, you just do it. That's standing order. What you can do, just show up and do it. Standing order. Standard of care means your actions during care. So standard of care, really the heart of it, what it means, what would another provider do in the same exact situation as you? Right? So you're a paramedic on this call, you're an EMT on this call, right? You take an action. The standard of care means would another provider take that same action? That's a standard of care. The normal average care of the situation you're in right now. Now you may have heard of a deviation from the standard of care. Oh, Jack deviated from the standard of care. What does that mean? Well, the heart of it, one of the possibilities is negligence. Negligence is failure to provide the same care that a person of the same training will provide. That's negligence at a base level. It can get worse. Gross negligence is willful or reckless action with total disregard for your EMS duty as a provider and or care of the patient. So these are our two levels. Let's go a little farther. Now there are three types of negligence that we have. So first is malfeasance. Malfeasance is performing an act you are not authorized to do. That is being outside of your scope of practice. Like, for example, let's say, for example, you were an advanced EMT and you give a medicine that only a paramedic can give. Or you're an EMT that performed a procedure that only a paramedic would be allowed to do. Or you're a paramedic and you perform a critical care skill. You get where I'm going with this? So that's outside your scope, malfeasance. Now with misfeasance, what we have is performing a authorized act. You're allowed to do it, but you did it wrong. That's like giving the wrong dose of a medication. For example, that would be like giving a pediatric the adult dose. Make sense? Great. Now, nonfeasance is a failure to perform an action when you should have. So let's say you had a patient and like the patient needed CPR, needed to be defibbed, right? And you didn't act, right? Or the patient needed epinephrine, and albuterol and oxygen, but you didn't act and you just drove no lights and sirens to the hospital, right? That would be nonfeasance, okay? So the cool way to remember is non, like no, like you didn't do it, it's not there. Miss is like you made a mistake, right? And then the only one left is mal. So that's the way I remember it. Now abandonment is when EMS discontinues, stops care. In simple English, we leave the patient without transferring care to anybody else. So this is very important. This is why I say we need to get a signature. I'm very happy that the patient signed for their transport. That's them signing for the trip to the hospital. But the second signature we need on every run form is the signature of the nurse or doctor or PA or nurse practitioner or whoever is at the same or higher level of training than us to sign for transfer of care. Who would you give report to on your patient? That is why we do this, so we do not get hit with abandonment, which is a type of negligence where we leave the patient without transferring care. Get a signature. Please don't forget that. Now, our final part here, I want to talk about ethics. You're going to have to make critical decisions, critical clinical decisions, patient refusing, patient going to hospital, whether or not to give medications, so on and so forth, as an EMS provider. When in doubt about making a decision, I want to give you a quick checklist that you can use here. So first, is this in the patient's best interest? Number one. And also with that being said, are the patient's rights being protected as well with that? Is the decision based on logic and reason, not just emotion? That's what we're looking at. Would you agree if you were the patient? Would you make the decision, or have you made the decision in the past in similar circumstances, right? So we're talking about same, similar, past situations. Would you make or have you made the decision before? And finally, can you back up and defend your decision you're about to make right now? If all these check that they're solid, go for it. This is a good place to stand on because you can document why based on this checklist. Pretty cool? There it is. Now, in this video, I'm going to talk to you about transfer of care and narrative writing and PCR documentation. Let's just explain what I'm talking about first. Transfer of care means the patient handover, the patient handoff, the report that we give to the nurse or the doctor or the PA or practitioner, whoever we report to at hospital. Remember, when we transfer care of our patients, it has to be at least an equal level or higher than us, right? So most likely you're transferring care to a nurse or a medical doctor in a hospital. That's the most common. Now remember this as well with the transfer of care. You're going to give your report. It could be on a non-life-threatening, isolated event, like let's say it was an isolated arm fracture, so it's not a life threat, but just a simple arm fracture, you could be transferring care to a multi-system trauma, what you're calling a trauma alert, a stroke alert, a heart attack, what have you. The transfer of care report is the same. The only difference is the amount of people that are going to be in the room. If you have a less critical patient, it might just be you and the nurse. And if you have a higher critical patient, you might have 4 or 5 doctors of different specialties and the entire ED team in there with you. You get what I'm saying? So this is what I mean by transfer of care at every level. This is the easiest mnemonic to remember transfer of care. SBAT. Okay? Now, and yes, with a T, because T is for treatment. So I'll explain. So S is for situation. What made this person call 911? For example, I'm bringing you a 35-year-old female. She was involved in a motor vehicle accident head-on into a pole. I'm bringing you a 64-year-old male. Sudden chest pain while sitting down at home. What is the main problem? What event took place, right? Why they call 911? They called because they had chest pain, difficulty breathing, and it happened 20 minutes before they called, right? It's a 10 out of 10 pain, right? What is the situation? Why did they call? What is the chief complaint? The background. You want to look at, after you obviously at this point in hospital, you've done your major assessments, you've gotten history on the patient, you've gotten background information on the event, you saw the scene. In all of that, what is the most pressing information that you need to pass on right now? I can give you an example, okay? Let's say I'll give you an example. 2 different patients. A 65-year-old male with chest pain has no risk factors, but he's got chest pain. This 65-year-old over here, right, for example, let's say his EKG is fine, his EKG is abnormal. He has risk factors, he doesn't, right? So, if I am in care of a 65-year-old male patient with chest pain 10 out of 10, what might be some of the most pertinent info? What was the EKG of the patient? For example, what if my patient had a history of diabetes or high blood pressure, high cholesterol, right? Or a recent heart attack or recent surgery, right? That's pressing. I bring you a 65-year-old male with no cardiac history and the EKG looks fine. Versus I'm bringing you a 65-year-old male who had a recent heart attack in the last 3 months and is a diabetic. EKG shows the patient's having a heart attack right now. You see where I'm going with that? So that's on you to find what's the most pertinent info. Okay? Assessment. Assessment findings. First off, what are the vitals? What are the vital signs? Okay, so what's the big problem? What happened? Is there anything really pertinent we need to know right now? What are the vitals? Now, this also includes your physical exam findings. So again, if there's something very pertinent, can I give you an example? Lung sounds are very important, right? In case of trauma, a pupil exam can be very important, right? Pulse-more sensory in trauma, that's very important, right? So we think about some of these things, right? In a gunshot wound, how many wounds are there and where are they, right? That's assessment findings. Now in treatment, as far as treatment, what have you done? Meaning, what care are you providing to the patient? What meds did you give? And what care did you provide? This could include just giving ice packs and a splint, by the way. This is going to be medications. So giving you a final review. What happened? Why'd they call 911? Based on everything that you've seen with this patient so far, what is like 1 or 2 pieces of information you need to know right now? What does your assessment show that's very important, that's a critical finding? And what are the vitals? What did you do? Here's your patient. There it is. Now we're going over for our EPCR, our electronic patient care report. We're talking about here is our narrative, how we actually structure a run form. Now, what a run form is, it's a document that you're going to fill out at the end of your patient care. So you've already done your transfer of care. If the patient's, adult years and sound mind, they sign for their transport. And you also get a second signature from the nurse or doctor that they received the patient at the hospital, and they are now in care of the hospital staff. Great. So with that chart, we have to complete the rest of it. And a large part of it is something called the narrative. So what the narrative is, it basically is a story that a story writing style, if you will, of you writing what happened throughout the patient encounter, right? It's you telling the story of the 911 call, and you're writing out what happened, right? Now, if you can't, it's a little small here. I'm just going to read this to you. Chart. This is the chart mnemonic. C-H-A-R-T. Chart mnemonic for run forms. For run forms. Run forms is kind of slang for your patient care report. So you will hear that. So it's good to know that. So the mnemonic is C for chief complaint. Well, what do we start our narrative with? Well, a great start is, what do we get dispatched for? We got dispatched, let's say in this case, we got dispatched for a headache. And then by the time we approach the patient, they're saying they have a headache and they're nauseous and they're vomiting in front of us. So now we've taken care of chief complaint right there. H is history. So what's the patient's history? Now I put here asthma and diabetes. That's their patient's history. But also, what's the history of the event as well, right? We know we have other videos in this course on sample and OPQRST and all those other mnemonics as well, DCAP-TLS. But let's just keep it just simple here and focus on patient history and also the history of the event. So how long has this headache and nausea vomiting been going on for, right? That goes in your chart. Assessments. So when I think of a focused assessment that I would do on someone with a headache and nausea vomiting, I would do a stroke scale. And I put negative, let's say a negative stroke scale. I've put here that the patient reports photophobia, so they don't want to really look into the lights. They do have equal hand grips, which is great. And the pupil exam is normal, so their pupils are not of abnormal size or condition. Now, what treatments did I do in this patient? Well, this patient has a headache and nausea vomiting. In this case, we're going to say that the patient was transported, with vital signs twice. Once on scene and once en route in the ambulance. They were transported, basically support by a 2 EMT crew, let's say in this case, right? Now, transport. Well, transport talks about patient movement also. So if we find a patient with a headache who doesn't want to look at the lights, then they're probably, let's say they were sitting on the couch or sitting in the bed. You want to document where were they found, right? Let's say this patient was found sitting in bed. Let's say this was an elderly female who's had a headache, nausea, vomiting, throwing up, and she can't really see the light. Like it's bothering her. I can't see the light. The light is really bothering her, right? It's just photophobia. The light is very much bothering you. Well, we're not going to, oh, come on, let's walk you out of the house. I mean, we're not going to do that. So we bring the stair chair in, get the patient to the ground level in the stair chair outside the home. Then the stair chair, we're going to do a team lift. We're going to lift the patient up into the stretcher. Now from the stretcher, we have to bring the stretcher up into the ambulance. Now the patient is secured in the ambulance via stretcher. We transport basic life support like we talked about. And then we need to get a transfer of care and signatures, right? If patients have adult ears and sound mind, get a signature from the patient. If not, then we need to get a patient care signature from the hospital staff for both the patient and also for receiving care of the patient. So that's key too. And there it is, chart. So now we have the SOAP mnemonic. Now you may have heard about this in class, the SOAP mnemonic, and you may have you get a question on it. So I want to make sure that you're clear on this. And I'm actually going to share with you right now a little twist and how I use it too for narratives. So first, let's go over the mnemonic. SOAP. S-O-A-P. Subjective, objective, assessment, and plan. Subjective means what the patient or other people like family, bystanders, first responders, other providers say to you during the call. Objective, what you see with your own eyes, like what you find on scene, what you see as you approach the scene, the patient's vital signs, patient's EKG, the patient's pulse oximetry, end title, like data. So subjective is what people talk about, what they say. Objective is, this is right here on the monitor. Make sense? Assessment, well, that's your patient assessment, right? That includes all the assessments you do as an EMT or paramedic. And the plan, well, that includes like, what did you do, your treatment, how did you move the patient from where they are, and then your transport decision making and how you transport and why. So that's this. Now let me share something with you. One big thing that I love about SOAP is this section, the subjective section. So commonly I'll start off my narrative with something like, EMS dispatch, what priority, lights and sirens, no lights, to this location for this, right? So we're dispatched, this priority to this. We got there without incidents, right? Then EMS makes patient contact. And then what do we see on scene, right? First. And then what I first assessment of the patient is, right? But also included in there is going to be what the patient exactly said out of their mouth. So the patient tells you, my chest hurts. You write down, patient states, my chest hurts. The family says, she has diabetes. You go, patient's family member states, she has diabetes, right? Why it's so important is because this information is happening to you on scene. If you don't write it down, it never happened, right? So let me ask you, how do you know the patient has diabetes? How do you back that up? Well, they stated it to you and you wrote it down. Now you back it up, right? Your objective, how do you back that up? Well, the cool thing is about the heart monitor, it prints out some of your vital signs information, right? Obviously, you want to make sure you time as best as you can, because we all know if you actually work in EMS, that it is impossible to do everything perfectly right at this time. But you want to get a general understanding of timing when you did what you did throughout the call. Okay? That's very important. If you can get the perfect time and you're that clued in, great. It's fantastic. That's what we're looking for. That's objective. So not only did you get vitals, but what exact military time did you get the vitals, right? Assessment, you've got to cover yourself with assessments. One thing I didn't talk about here, and I do want to mention before this video ends, is pertinent negatives. So a pertinent negative is this. So for example, let's say that someone has chest pain, right? And we know that there's cardiac risk factors for chest pain. There's a mnemonic for that, SAD CHF. Smoking, advanced age, diabetes, high cholesterol, hypertension, high blood pressure, family history of dying of a heart attack, right? So those are risk factors. So if the patient says they don't smoke, they're, they don't have advanced age, they're not over 40 or 50, for example, right? They're not in older adult years. They don't have diabetes, they don't have high cholesterol, they don't have high blood pressure, and no one in the family died of a heart attack. Those are pertinent negatives. So I would write down in my chart, patient denies diabetes, patient denies high cholesterol, patient denies high blood pressure, patient denies family history. What this is doing is not only giving your patient care report good brevity to see that you covered everything that you're doing, but it also covers your butt if something sinister happens to the patient. You need to show on your documentation that you asked. Did you ask for cardiac risk factors? Did you get a full patient history? Right? So this is some of the keys. You'll see more about this as we go through the course, but that is so key. Anytime you have a chief complaint, okay, what is something that if the patient has a history of it, or if I see it, it's really bad? I give you another quick one, for example, right? Well, you talked about in this earlier on about headache, right? So a patient has a headache and they have nausea, vomiting. What's the first thing I'm thinking about? Well, could it be a brain bleed? Could it be a stroke? The first thing I'm going to do is check equal grips. The first thing I'm going to do is get a blood pressure, and I'm going to check to make sure they're not hypertensive. The next thing I'm going to do a stroke scale, right? So if you always think worst case scenario, it's great to think that, but you got to document that. And that's where pertinent negatives come in, my friend. That makes sense? Okay, good. This list right here goes over all the main moving and lifting patient equipment that you will see or need to use as an EMT or paramedic, of course. Now, here's what we have. I'm going to try my best to get a picture of all these for you. And as I talk about them, place them right here for a few seconds so you can see them. So first is the ambulance stretcher. Now, we have a manual stretcher and we have a power stretcher. We also have a bariatric stretcher. So we could say there's basically three main types of stretchers. The ambulance stretcher is how we get the patient from the outside world into our ambulance and transport them, right? And it has 4 wheels on it, of course. There's also in the back part of the stretcher usually in most stretchers, there'll be a little, there's a little basket to put some extra sheets, blankets, some equipment like oxygen supplies. You can, obviously there's a hook there, to put the heart monitor on the back of it as well. You can stick some equipment under there. That's pretty cool near the head of the bed. And then you usually use an IV pole as well, on the ambulance stretcher itself. There's also room for an oxygen tank on the back of the stretcher as well. So that's pretty cool. So what I mean, a power versus manual stretcher. Let's talk about that first. So a power stretcher, there's a battery in the actual stretcher itself, where by the press of a button, I can bring the stretcher up and down, right? With a manual lift stretcher, I have to get into a lifting position, and physically, there's a trigger. I have to pull the trigger and then lift up and down to make the stretcher go up and down. It's a manual lift. It involves more labor of the body. I can just go like this, and even just go like one hand, but you can just press the button to lower and bring it up without doing a major lift. So I actually did a poll to all my students in our community group a few months back. And I asked, does anyone still use a manual stretcher? And I found it was about 80% with power and about 20% with manual. But it seemed that if they had some manual, they had manual, a lot had manual and power. So you should have a power stretcher, but you also need to be aware of how to use a manual stretcher because it's part of the job. You need to know how to do that, right? Now let's talk about the bariatric stretcher. The bariatric stretcher, all that is, it can be in power or manual. And the way the bariatric stretcher works, I'll show a picture of it right here, the bariatric stretcher. There it is. And this stretcher is a little more wide and it allows more weight for the bariatric patient to be able to be transported. All right. Now the backboard. The backboard is a device that for so long in EMS was used for spinal protection. The idea was that if we keep the patient flat on a spine board, a flat board, that's going to help their spine. Studies show that can actually hurt the patient more than help. So now, for the most part, backboards are used as a transfer device. So if we have a patient in a weird, awkward placement, maybe on the floor or something, and we just need to get them onto a device to get them out of where they are, or we have made a longer distance to carry them, or awkward home environments, this is a place where we might use a backboard, right? A motor vehicle accident, you could use one too. That's also possible. So the backboard is really more of a getting the patient to the stretcher device more than anything, right? A slide board or a slide sheet. So there's actually a thin, I'll try to get a picture of it here, a slide board or a slide sheet just so you can see it too. So the slide board, what that is basically is you may be called, actually this could be a 911 call too. Whether it's a 911 call or interfacility transport, meaning that you were called to a hospital or you're called to a nursing home to transport someone to a dialysis appointment, or if you're working 911 EMS, someone's just laying in their bed and we got to get them from the bed onto our stretcher or stair chair or whatever we're doing, right? This sheet, this board, we're basically going to roll the patient, get them underneath the board or the sheet, and then we're going to team lift them over into either the stretcher or the stair chair or what have you, right? And obviously, if this is the bed, we're pulling like this. So you're going to have good leg, good leg bend, and you're going to pull towards you like this. Right? If you're on this side, the other side is going to be kind of holding through. Okay, so that's how it works. There's your slide board, slide sheet. Next, we have the stair chair. So the stair chair is used when people are non-ambulatory or we don't want them to walk, but they're on the second or third floor, and we need to get them to the ground level where the stretcher is, right? You don't bring a stretcher up to the third floor of someone's house into their bedroom. So that's where the stair chair comes in. So if let's say they're in bed, we got to move them, using a slide sheet, right? In bed, take the slide sheet, and then we can get them onto the stair chair, secure them to the actual stair chair, bring them down the stairs in the stair chair. And these stair chairs, I'll try to get a picture of it here if I haven't put it up yet. With the stair chair, I would say 90% of stair chairs are the Stryker stair chair that have this back piece of it where you can glide downstairs instead of having to carry the whole time. So with a stair chair, you can either carry the patient down or there's these back tracks, we call it, and it'll track the patient down the stairs. The issue is you can't use tracks in a stair chair if we have a windy staircase. So we have to carry in that point. So we can use tracks if it's a straight stair. So we got a few more things to talk about. Our scoop stretcher. So I have a few things here. Scoop stretcher, basket stretcher, backboard. These are all in the category of, I got a patient either in a austere environment, austere meaning like a environmental, cold, hot, out in the wilderness, out in a, out on a hike, think like that, right? Or out in a cold area, out somewhere far away from the main roads. Picture that scene if you can with me, right? That's where we would use more of this, basket stretcher. Now a scoop stretcher, that is simply, basically, it's an alternative to the backboard, right? So backboard and scoop stretcher, these are used to get the patient on our ambulance stretcher when they're in a kind of a weird environment or an awkward position, right? The basket stretcher is most commonly used in an austere environment or where we just have we have to walk a long ways to get back to the ambulance and the stretcher. Again, I'm thinking about the wilderness, right? Like, that's where you use a basket stretcher. Also, a basket stretcher could be used by, for example, a helicopter team, right? To rescue, in special rescues. Basket stretchers could be used. You bring that thing down, get them on there, and you can get them up. So that is also something as well, right? I would say the majority of ambulances have the ambulance stretcher, a backboard and a scoop, some sort of slide sheet, hopefully, that's what we hope, and then a stair chair. Basket stretcher, usually it's more of a fire department thing, but it doesn't mean EMS can't have it. Just, it's not as common, but you can have it. The last thing here you'll find in critical care transport or interfacility transports is called a neonatal or a neonate isolette. So if we have a patient who is a very ill or critical neonate, well, they're basically in their, their base is essentially like an incubator, basically. So it's a transport. So what we have is a warm and clean environment for this neonate to be transported in. That's the neonate isolate. Just like it says, it's isolate. It's isolating them from the environment because they're sick or ill. So they have a clean, warm environment to be in, right? It's kind of like an incubator if you think about it like that, right? So this actually goes in the back of the ambulance. So there's different setups for this. I'll try and get a picture of one here for you. This setup is going to be determined on your agency and how they have it